Good afternoon, everybody. Figure this mic out. Good afternoon, everybody. Is that working? We on? Everybody hear me in the back? Good deal. Thank y'all for being here. Some of y'all we've now got to see for 3 or 4 times. We appreciate your passion, and I think y'all know this committee is committed to the law that was passed in HB 65 on figuring out a way that patients in Georgia can find access to THC medical oil. But before we begin this meeting, we're going to start off with a prayer. President Pro Tem Butch Miller will lead us in that.
Yeah. Can we go to the Lord in prayer, please? Our Heavenly Father, we are grateful for the fine people who've gathered here today, and I know they're here to do good work. We ask, Lord, that you bestow upon all these folks wisdom, justice, and moderation. For it's in those qualities, Lord, that we enjoy a life in the state of Georgia and a future in the state of Georgia that is beneficial to all concerned. We ask, Lord, that we do all these things in honor of you. It's in your holy and precious name we pray. Amen.
Amen. Thank you, Senator. Now, if everybody would join us in the pledge. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, most of y'all, everybody know everybody on the commission here, but I'm going to do a quick reintroduction. Again, we got Senator Butch Miller, President Pro Tem of the Senate. We got Susan Driscoll, who's a citizen appointee. We got Representative David Clark of the 98th District.
Representative Chairman Alan Powell, Public Safety, Homeland Security. Dale Jackson, Shannon Cloud. My name is Micah Gravely from House District 67 in Douglas and Paulding County.
All right, again, let's go over the rules again. Most of you already know them. New number 1 rule is everybody turn off your phone, or at least silence your phones. That used to be number 3, but that just became 1 from one of our presenters of all things. So yeah, if everybody would just check your phones briefly and make sure they are on silent. But most important rule we got is be respectful of each other, be respectful of each other's opinions. Not everybody agrees on this subject, but we are going to agree to treat each other with the respect that is due. So if anybody breaks that rule, you will be asked to leave. When we get into the public comments, again, I want to stress that we want to stick to talking about access. We're not here to debate the current law. We're not here to talk about adding diagnoses. We're not here to talk about recreational use of marijuana. We're here to discuss medical oil and how that access can help Georgia patients. But with that, everybody's been great so far. I think in our last meeting, there might have been a word or two that we probably shouldn't use. So if everybody would just be respectful of that, and let's keep our language clean. And I think everybody has agreed to do that. But with that, Representative Gravely, did you want to talk about the bill again?
Yeah, thank you, Senator. Again, I would echo the sentiments of Senator Brass. Thank you for everybody who is here today. Thank you for our law enforcement officials. Sheriff, thank you for being here today. For those of you that drove quite a distance to be here, to give testimony or to be here and to take notes or to support a loved one, a family member or a friend, thank you all for being here as well. What we are here to discuss today is House Bill 65, the creation of a low THC medical cannabis oil access study committee. We have, over the past couple of years, through the efforts of Alan Peake and members of both the House and the Senate, some of whom are represented on this committee, started working in 2014-15 on a bill that would allow patients in the state of Georgia to access medical cannabis oil. In the last 5 years, we have been able to make eligible the following diseases, and I want to just make sure so everybody knows what we're talking about, what diseases are eligible. In House Bill 65, the current list of eligible diagnosis in the state of Georgia are the following: cancer, amyotrophic lateral sclerosis, seizure disorders related to a diagnosis of epilepsy or trauma-related head injuries, multiple sclerosis, Crohn's disease, mitochondrial disease, Parkinson's disease, sickle cell disease, and what was added in the last 3 years, Tourette syndrome, autism spectrum disorder, intractable pain, post-traumatic stress disorder, Alzheimer's, HIV virus, acquired immune deficiency syndrome. Those are what is, these diagnoses are what is currently eligible in Georgia's law. We have about 5,000, approaching 6,000 registered patients in the state of Georgia who have a medical cannabis low THC card. They are eligible to possess the oil. We have about 600 doctors who have signed up through the program as well. So what we want to talk about is how do the patients in the state of Georgia get the oil. Many don't know how to get the oil. Many have a card and have never been able to get the oil. Many were getting the oil from a certain source. That source can no longer provide the oil. Some folks have had to rely on mail order. In that situation, they don't know what they're getting, but they have reached their wits' end with the opioids. Either they don't want their loved one or their child on the opioids. So they're grasping at straws. They know that this works. They've either talked to other family members, they've maybe talked to a physician or another doctor who has recommended that maybe they try this. It's a last resort for some folks. Some folks who are finding out these diagnoses now are immediately starting to treat with this and don't have to go through treatment cycles with opioids. So we're here to talk about how we in Georgia can create an infrastructure or a protocol that would allow these patients access. You're going to hear testimony today. The members of this panel are made up of not only citizens advocates or elected officials, industry professionals, but parents who have loved ones or children who have been suffering. So as we get started, again, just be respectful. It's been fun and exciting, sometimes entertaining to hear or to see what's going on, but the testimony that's going to be given is in some instances, very painful, very emotional for some of the people who have had to deal with unthinkable diagnosis. It's also, we want to be mindful of this. Our law enforcement personnel, they're trying to deal with this as well. They're trying to deal with not only going home and being with their families at night, trying to, a lot of times we don't know in this day and age, and that's something that's a very serious problem, but they're also trying to, what role do they play in this? So we want to be respectful of their service and what they're here to do as well. Senator, we're going to get started with our first presenter.
Yeah, and before we get started, real quick, we've got Representative Spencer Fries here. I just want to acknowledge him. We appreciate any legislator that takes time out of their busy day to come watch this when, I'm sorry, and Representative Deborah Gonzalez as well. I didn't see her. Sorry. Thank you all for being here. And then I know Senator Bill Cowser is on his way as well. So, again, thank y'all. So first up, actually, our first presenter texted me this morning, and he's sick and can't make it. And I actually left someone unintentionally off the agenda, so I'm actually going to fill him in that role. But Neil Brigham is going to come up and talk about the operations and processes in other states. And keep in mind today, and Neil, if you'll just come on up to the podium, today's kind of topic and subject is we're really looking at other states and looking at what they're doing and trying to learn from them as much as we can. The things they're doing right, the things they're doing wrong. And so that's kind of what today's topic is, so just keep that in mind. So, Neil, your microphone is on, so whenever you're ready to begin, you have at it.
This controls the slides?
Yes.
that in presentation. There we go. So I got 2 questions for everybody. So what happened 4 months ago and what happened 2757 before Christ? Any guesses? Okay, 4 months ago I got a phone call from a friend of mine and said, what would you think about becoming the chief operating officer of a medical cannabis company? And my response to him is, what are you smoking? You kidding, really? I've been a partner for 20 years with Arthur Anderson, Accenture, KPMG, and most recently with Alvarez and Marcel. I've done corporate turnarounds, corporate restructurings, building companies, launching new businesses, and everything else. And when I got that phone call, I said, let me look into that, which gets to the second number, 2757 before Christ. That is the first recorded use of medical marijuana, and that was in China. And cannabis has been around for 30,000 years. It was used for medicinal purposes until 1937. It was legalized in the U.S. in 1851. In 1937, it was criminalized. Mainly what was criminalized was hemp, because it was a direct competition to the emerging petrochemical industry, because hemp could basically replace all the petrochemicals in the U.S., and also was a direct threat to the cotton industry, because hemp fiber was a direct competition to all the cotton fiber. So guess what? Some politics intervened, and hemp was made illegal, and 4,000 years of being used for medicinal purposes was eradicated, so that now it was a very bad thing to be talking about. So when I came into this business, I said, I don't really know what this is all about, and I need to know I have the highest level of integrity and professionalism. If you look at my career or talk to any companies I've worked with, you'll understand that. So I had to understand what their mission was. And the mission of this company is really about empowering wellness, focusing on people and focusing on impacting their lives. I had a personal interest in that. I have been blessed to be married for 34 years. My wife and I have 3 kids. We have 4 grandkids. I have had unbelievably superb health, and my wife has had the exact opposite. So she has had all kinds of different surgeries and things that she's had to go through, and every time they wanted to offer her opioids, and each time she refused the opioids. She said, I'm not going to take opioids. I don't agree with that. I don't believe in that. And so I had a personal interest as I started to read about this and understand the opioid crisis that was going on in the U.S., and was there any other solution out there? And what I learned was, heck yeah, there is. There are 421 chemicals in cannabis. There are 80 different terpenes in cannabis. Most of the U.S., we do not understand the impact of that, and we have not done the medical research because it's been illegal. And yet, if you look at the 4,000 years of history, clearly had an impact on people and could deal with that. If you look at the endocannabinoid system within the human person, that is neither understood also because it's been illegal to do that type of research. So we have large pharmaceutical companies who are pushing their agenda onto the human population on what they want to do, but they do not want to use a natural product because then they will make less money going for the natural product. So when I started to learn about this and research it, I went from, what are you smoking, to saying, yes, I absolutely want to be involved with that. Then came my next learning. So what the heck is this, and how do you do this? And in Florida, where you have to be a completely vertically integrated company, go from seed to sale, what does that mean? And what that means is, first of all, you don't go from seed, because you take all clippings from mothers, right? So this is, the whole idea of seed is erroneous. The second thing is there is a set cycle, and I'm a supply chain guy. It takes 127 days to go from the clipping of the mother to actually having the flower that you produce. And then once you have the flower, then you have to dry the flower. It goes through certain processes. Some are better, some are less. Carbon dioxide is a better way to go than my way, than going through the butane approach. But you have to extract the oil. And once you extract the oil, then you have to look at how to go through the distillates, and then how do you get it to the customer and focus on the wellness. So all of a sudden, you had to become an expert in multiple different areas. And learning about that, I said, all right, so let me understand what those processes were. So I walked in for the first time ever into a greenhouse filled with marijuana, and I looked at it and said, oh my gosh, look at all this. And in fact, funny story, we just hired a fellow who heads up my asset protection. He was a 32-year career law enforcement professional out of Florida, also FBI trained, and every time when I walked him in there for the first time, he joined us 2 weeks ago, he said, Neil, I kept reaching for my gun because I want to say to everybody, freeze, don't move, because look at all this marijuana. And he goes, and now I'm your head of asset protection because I only want to hire the finest, and we all know that the law enforcement professionals we have in this country are the finest. So Mike looked at that and he said, this is amazing. So you have on the top left, you have actually the mother plants. So the mother plants, you grow the mothers up, they get to about this high, you take clippings off of those. The clippings then go into a coconut shell basically mulch. You grow them up into the little plants, right, which you see in the middle there, and then as they grow, then you're growing new mothers, or you're going to put them into flower. Now, what's unusual about our process? You don't see grow lights, you don't see these in container buildings. You see this done under Florida sunshine. It could be done under Georgia sunshine. Our belief is that you should look at how to work with the natural environment in doing that. However, you cannot let the flowers go to seed. If they go to seed, then you're not having the seed to create the oil that you want for the product. So if you look closely in the picture, you'll see black lines up there. Those are blackout curtains. They roll close at 7 o'clock at night because you need absolute pitch blackness, or the flowers will think it's time to go to seed, and they'll go to seed. And by the way, and many of you have been down in Georgia or Florida, it gets a little warm in the summertime, July and August, so you have a greenhouse inside glass where the sun wave comes through and it gets hotter, and you have plants and you're trying to grow the plants and not burn them, and they need to have a certain temperature. So think of the ideal location for growing marijuana, Napa Valley. That's the ideal location. That's not central part of Florida. So the blackout curtains are there, and then massive amounts of HVAC cooling to cool the plants. So when we look at this, we have a 127-day cycle. We have 2 greenhouses. One is going to be 486,000 square feet. The other one is 400,000 square feet. When we have it all set up and operational, we'll have 500,000 plants growing at any one point in time. You need that type of volume because you have to go from the plant to the wet flower to the dry flower, from the dry flower then to the extract oil. So what is the extract oil? All right, so for those of you who have driven through Newark, New Jersey, you've seen the big distilleries, and this is a really small version of the same thing. So you dry the flower down to a certain level of humidity, 10%, then you put it into basically your coffee grinder and create a flower grind, and then that goes in big Tupperware containers, which then get put into the thing on the right side there, on the left side there in the extract process, and then through hydraulic pressure, you squeeze it down, and from that you get the extract oil, and then it goes through additional processing. And then once you have the raw extract oil, then you need to understand the chemical aspects of that and what you're trying to create, because again, there's 421 different chemicals and there's 80 different terpenes. So how do you get all those things to have the right thing that you want to have? And then as you create your process, you have to have a quality control function to make sure that you're you're having the right quality. So if you have a product that is 10 milligrams of THC and 80 milligrams of CBD, or whatever the ratio is, it has to be that. It has to absolutely coincide with that. So that's that part of it. Then, how do you get into the enable piece of this? So then you have to look at how to deliver it to the customers. Most of the customers do not understand the product because it's not been available. Most of the people in Florida who have the right to get the product don't even know they have the right to get the product. So you need to bring them into an environment that is friendly and welcoming to them. We designed ours to look like a kitchen counter. You come in, you sit around the kitchen counter. It's a very friendly, encouraging environment. All of our wellness coordinators are far different than your store clerks at most stores. They need to understand what we have. They need to understand how they respond to what the people want to have. They also have to make sure that they get the proper certification from the people, that they come from the doctors. There are 50 pages of regulations from the Department of Health down in Florida on what we need to do. There's another 450 pages of interpretations of those regulations, and all of our people have to be briefed on all 500 pages because as they work with every single customer, they need to make sure that we're doing the right thing for the customer. Again, our focus is on the wellness of the people, and there are other companies out there more focused on the dollar. Go figure, surprised by that. But we really are looking at how do we deliver this to the people in the right way. We have private consultation areas where we'll sit down and we'll talk with them. It is not a high volume transaction. We are not bringing people in and processing them and pushing them out the door. A person can be an hour to be with us and end up spending $120. So that's a pretty big investment, but our goal is to get the people the right things they have. Every week we get basically one of our people. She publishes for us a listing of all the stories that we heard that week from all the customers. And having now been in this role for a few months and having read week after week after week after week of people who've been impacted, whose children have epilepsy, or soldiers who have PTSD, or other people, and hearing every single testimonial about that, I'm absolutely convinced of the impact of medical cannabis and realize that it is very much misaligned within the public image. So we have these people who are delivering that. Then how do we get it to them? So you can't just drive around the streets with marijuana in your car, okay? That's not a good idea to do. And so we have unmarked vehicles. We have 23 unmarked vehicles. Each one of the vehicles has security grates in them. We have lock boxes in there. We have 7 cameras on the vehicles. We have 4 GPS on the vehicles. If a vehicle gets stolen, it automatically locks down the car. It won't drive anywhere. You won't know where it goes. We have a command center which my friend Mike is now responsible for. We have 8 cameras in every single store, plus the cameras in the vehicles. So we track every single shipment, where it's going, who it's being delivered to. A lot of people, once they've come to the store once, they don't want to go to the store again. So they can come to us and say, I want to have it delivered to my home. We do next day delivery to them within a 2-hour window. Right now we're at 96% percentile of delivering on time within the 2-hour window. So as you think about it, just saying I want to have medicinal cannabis delivered out to our citizens of our state means you got to think about all the processes. And you have to understand how to go through that grow process, through the extraction process, and then through the customer interaction, the client interaction, make sure you're serving up the wellness that the person is looking for. And then you need to look at what your workforce look like. This is our workforce. These are our people who are interacting every single day with the citizens of Florida. They look pretty dangerous, don't they? So look at those people. Each one of them is absolutely passionate about how do we support and how do we help people and how do we serve the people and what are we trying to do to help them in their various lives. So it's a very complicated process. Then you say, okay, so what's going on with the legal landscape? So I didn't know this 4 months ago because I've learned a lot in the last couple months that I've been on board, but 36 states right now have legalized medicinal marijuana. And of that, and then also in addition to that, there's a lot of momentum in the other states. It goes all across the boards in terms of how people are impacting that or delivering that to their customers, all kinds of different variations, all kinds of different schemes that people take. I've traveled to California. I've seen what they've had there. I've looked at their dispensaries in California. I looked at the dispensaries in Las Vegas. And I have seen things that are just amazing, some things that are appalling. And one of my key messages to you on my final slide is what things should Georgia be considering. You should be considering companies who are very professional and look at this and how to do it the right way with a focus on the empowering of the individuals. All right, so legal landscape, I talked a little bit about this. It was legalized in 1851. I talked about 1937 when it was made criminal. And then there's been some evolutions through that time for different things. Where is it right now today? States are still concerned that right now, if you look at the bottom right, Jeff Sessions rescinded the Cole memo in 2013. He basically left it to the state's discretion on whether or not they wanted to pursue people for this, which are giving some states pause about should they go forward or not. All the evidence that we have and all the discussions we have is it is going to go forward. The States' Right Act will go through. The current Hemp Act that's being looked at is probably going to be going through. So sometime in the next 2-3 years, it will be, my view, it will be legalized in the U.S. And not legalized, okay, now here's everything you do. It's just be the states can do what they want to do. The Fed's not going to mess in their area. And if that changes, then that's going to be a massive change for everybody. If you turn on the TV, you'd have to be brain dead not to pick up a story about medical cannabis. Everybody looked at Tilray stock. $20 million revenue. Their stock last week hit $20 billion in a market cap. That's insane. Why would you give a company of $20 million revenue a $20 billion market cap? People look at Constellation Brands. Why is Constellation Brands getting into cannabis? You go have a beer, right? When you're done your beer, right, what do you have? You have calories in your body. If you drink too many beers, you're drunk. You have a hangover. If you drink alcohol too much, I have a friend that had this unfortunate, horrible situation, died of alcohol poisoning. If you drink a lot over a long period of time, you get cirrhosis of the liver. If you have a cannabis-induced drink, in whatever drink. But anyways, if you have that, no hangover, no calories, right? You can't die of an overdose from a cannabis drink. And that's why everyone's racing into that area. You hear about Coca-Cola here in town trying to do something. They're looking at Aurora growth and what to do. The issue with that is oil and water don't mix. So cannabis oil does not mix with water. And if you want to have a beer with your friends, you're going to feel a little bit of a buzz in 15 minutes. And if you want to have a cannabis drink with your friends, it will take your body 2 hours to digest the oil before you feel anything. So everybody is trying to figure out right now how to get to the end solution. The end solution is nano-encapsulation of the oil molecules, and then it can be absorbed by the body because our body is mainly water-based. So that is going to come to us very, very quickly. Every large drink company out there is looking at it. Diageo is looking at it. Constellation Brands and others are all looking at it because they realize that they're going to have massive erosion of their current marketplaces. So it's coming fast and furious. So then the last thing, my last slide, is considerations for Georgia. All right, the first thing is there's a lot of misunderstandings. 4 months ago, I was one of the people with the most misunderstandings. And now here I am talking to you as a COO of a medical marijuana company. There's a lot to be learned. A lot of people have bad impressions of what it is. They remember it from high school or college, but they don't have any updates since then. They're not aware of all the things that have evolved, the changes that have evolved. The second thing is there's a lot of confusion. What's cannabis, what's marijuana, what's hemp? It's the same thing. Marijuana is the slang name of cannabis. Cannabis and hemp come from the same plant. It's just slightly different plant in terms of the THC and the CBD compounds and the mixture of those compounds. Hemp is currently outlawed, but you're still going to have a lot of products showing up today that are, say, hemp-derived CBD oil. Well, you can't have hemp-derived CBD oil, right? But their products are showing up, but there's massive benefits to a lot of those products that you can get, and you don't get the high of the THC. So there's a lot of confusion about what's out there and what it is, and people just give a general categorization, but they don't really think about the impact. Next one is you should have an absolute relentless focus on Georgia citizens and the wellness of the citizens. As a citizen of Georgia, I live in Atlanta. I've been here for 20 years. I'm always looking to government and saying, are they representing my best interests? And my view is if you're going to give me medical options that are organic, that are healthy, that are basically controlled in an environment that I want, then I'm going to be happy about that. When I went out to California, they passed a law on July 1st this year. Before that, you can consume any marijuana you want to consume, no matter how many pesticides or heavy metals were in it. And lots of people were consuming all kinds of very terrible drugs. And if you take pesticides and you burn them and inhale them, they're even worse for you. So creating massive issues for the citizens because they had too open a law and they weren't focusing on the wellness of their citizens. So as we look at Georgia, we need to be thinking about that and what we're doing here. And then structure the regulations for the companies who want to come in, that you want to have come in here. Everybody wants to be in this industry. Everything you pick up says this one, that one's going to move into the industry. I got a brochure of the Mike Tyson brand, and Mike Tyson has a whole new offering he's offering out there. And he had the pro forma financials, and last year it was $570,000, and next year is miraculously $73.4 million. I'm not sure how you get that in anything. But basically, everyone's trying to put their name on it. If they're a celebrity, whatever, I'm in the industry, I'm relevant, I'm pertinent, it's going to happen. So you have to decide how we want to have it happen here in the state of Georgia. My view is have companies like ours, and it's commercial, I admit it, readily admit it, that are professional and are looking at this and saying, what's the right approach? And our focus and our mission is on the wellness of people. There are other companies that are only here for dollars, and they're trying to go as fast as they can and driving dollars. I don't think that's exactly the kind of company you want to have. There's other companies that are looking to skirt around the regulations and don't know the 50 pages in Florida and the 450 pages of derivative regulations, and they're looking at how to skirt around things. That's not us. We look at the regulations and say the regulations are there to protect the citizens, we're going to protect the citizens. Other things to look at is you want innovators. We don't know a lot about the industry yet. We need to know an awful lot more about it. We're still learning very, very quickly what's going on in the industry. You want people who are going to partner with the regulators, not fight them. You want someone who's going to work with them because the regulators, guess what? They don't understand it either, and they're learning at the same time. And at this point in time, most of the companies like our company know a lot more about it. So we work a lot with Courtney Coppola, who's the head of the Department of Health down in Florida, talking with Courtney, educating her on various things and different alternatives and different approaches to take. You want highest integrity and professionalism. There are a lot of people out there that do not have that, obviously. And you want people who have the financial strength that can be here, set it up properly, and put the resources. So that's it. Those are my comments I want to share with you. The key thing I want to try to get across is taking you the journey that I had from 4 months ago to today of how quickly you can learn something once your eyes are turned to it and you start to think about it. So I ask people to open your mind, read, understand, and really look at what's the potential impact here and realize that if there's something's going to happen, it probably is going to happen. It's going to get deregulated quite a bit. Get in front of it. Don't let it be done to you, but do it the way you'd like to do it. So that's it. Probably ran over on time. If I did, I apologize. But any questions or anything else you'd like me to cover?
Thank you for your testimony. Could you very briefly speak? You mentioned that there were 2 federal measures, the States Act, and then was there a mention of the hemp? I don't know if it was in the Farm Bill.
Yeah, where was that one? Yeah, it may actually, I don't even know if it made it into the slides. Yeah, so there's one that right now, that Mitch McConnell is really more behind at this point in time, looking at the hemp and what needs to be done for the hemp and that approach. And then the States' Rights Act is more in general, all the states looking at what they need to do. So those are the 2 main things. The hemp, we expect, is probably going to come through in the next several months, right? And then that'll be legalized. And then in terms of the States' Rights Act, maybe the next 12 to 15 months. That's what we're hearing back. Of course, no one can predict politics.
Well, I want to follow up. let's say the States Act, the States Rights Act is passed, becomes law at the federal level, does that have a provision in there from a scheduling standpoint to go from a Schedule 1 down to a 2? Would that, if Georgia said, well, now we're autonomous, we can do what we want to with this particular substance, does that allow our universities, does that allow medical professionals or our research institutes to
Start researching.
start researching without any type of fear that the federal government would come in and take licenses or withhold federal dollars?
Yeah, I'm not close enough to that in the 3 months I've been there, but it's a great question.
Thank you.
Anyone else? All right, I just want to thank all of you for what you're doing to really focus on our citizens and our people. And I want to thank our law enforcement professionals. I am a huge advocate and supporter of our military and law enforcement. It's probably part of the reason I hired a guy from law enforcement to head up my asset protection. I don't think that our law enforcement people get enough blessing from the people, and we give them a lot of aggravation, and we should not. So, gentlemen, thank you very much for all that you do, and thank the rest of you for your comments.
Thank you, Neil. All right, next up, we got Dr. Jessica Spencer. And Dr. Spencer, if you would just give us a brief introduction of yourself, and then you can jump right into your presentation.
And I will try to keep it at 10 minutes. I know your time is valuable. Thank you so much for letting me be here, actually, because I am from the state of Florida, but I've also been told to say that I am not a Gator fan. So I know I'm in the right place. So go Dogs.
And feel free to give you some applause on that.
I think they got it. I know there's a saying I'm supposed to say too, but that's a little bit above my pay grade at this point. So I am Jessica Spencer. I am a Florida resident. Can you hear me better now? Awesome. I am a 20-year professional in substance use prevention and treatment. I am a certified addiction professional and a certified prevention professional. I am really excited that you all, I'm going to hit my clock, I'm really excited that you all are actually here, and then that you guys are holding this commission, because it's extremely important, and I'm so glad that Sir Tara actually mentioned, being professional and making sure that you are keeping the best interest of the people in mind. So thank you for being here, and thank you for what you're doing. I don't know where the clicker... Here we go. Okay, so I'm going to go as fast as I can because I know your time is valuable. In Florida, we have certain regulations, and these are just some suggestions for you guys to think about and move forward in an effort to protect the people, and also to keep in mind the people that are interested in the services and potentially feel that they need the services. Our physicians are not able to have a direct or indirect interest within the industry or with a specific dispensary or lab. They are also required to have an annual education course. I understand that Georgia doesn't have that right now, but it was a suggestion, so I would urge that you follow through with that and maybe even increase from 2 hours to 3 or 4 or even beyond as information comes forth and more data and technology and education is out there. Conduct the patient exam while they're physically in the room. Prior to Amendment 2 passing, what was happening is that doctors were having Skype medical visits. That is not a medical visit. You cannot obtain and figure out what's going on with the patient without them being in front of you, especially for some of the conditions. Also, if a person is under the age of 18, we require 2 physicians to supply a recommendation. This ensures that it is in the best interest of that patient, and also to make sure that they are actually qualified to treat the disease that they are actually writing a recommendation for, and it isn't just a physician that's writing a recommendation willy-nilly. Only low THC for pregnant patients. This is concerning because unfortunately there's more and more data that comes out. There's several rat studies out there actually that show the teratogenesis 3 generations down from marijuana use with pregnant patients and pregnant rats. So that's something to possibly look into in the future, and keeping it low THC or not at all. Reviewing of the PDMP, I will say I don't know if Georgia has a PDMP, so if you do, great. I would make sure to add it in there that they can look for aberrant behavior within their patients and keep an eye on what's going on and what their prescription drug use history is. There is a correlation between marijuana use and prescription drugs. Physicians who's making the recommendations, the reason why I brought this up too is I don't know in Georgia what the definition of a physician actually is. So that might be something that you want to look at. This could be someone in our state that has actually lost the right to use their DAA, which is for a prescription, but it still looks into what their actual business practices have been and if they have gotten in trouble in the past for not taking care of their patients in the way and manner that we would hope they would. So that's something that you can look into. We look into the marketing for physicians. I think when we talk about professionalism and making sure that this is truly about helping individuals that are in desperate need and are really looking for something that's going to work for them, that maybe something hasn't worked in the past, we need to be careful with our marketing and how things are marketed and perceived in our communities. Our dispensaries are not able to advertise and market in that way, but our physicians are. Again, normalization and commercialization with the pot leaves. This, I know you're not talking about recreational, which I love, and I think it's really, get this correct, figure out what you're doing, but what we are seeing is companies coming in and trying to take advantage and move forward. Again, physician marketing, we have the normalization and commercialization. Street signs, legal weed. So I don't see a sign anywhere that says legal Nexium for your, do you know what I mean? So this is just, these are the things we need to be looking at and what kind of message is being sent in the community. Is this truly about medicine, or is this just about getting high and getting weed legally? Blimps, we're seeing those along our beaches. Again, like weed, get legal. We're supposed to be talking about medicine. So interesting to look into what your marketing requirements or regulations are going to be here in your state to make sure that you, again, as Satara mentioned, the nefarious companies that will be coming in just trying to make a buck and trying to make money off the backs of people that are really suffering. More physician marketing, false claims about being able to solve the opioid crisis. The interesting thing about that is please, and I do have data and the graphs from all states that have legalized recreational and medical marijuana, please look into the CDC opioid overdose data. In every state that has either legalized recreational or medical, the opioid deaths have actually increased, and those can be supplied if you do need those. Again, we're talking about medicine. Thank you.
Good. With your testimony, guys.
You're fine.
Again, as we stated, we are going to have some disagreements. There's going to be testimony that folks understand. There'll be other testimony that either supports or challenges those facts. But what we need to do is maintain a professional decorum and allow the presenters to present, okay, guys? We're going to offer everybody that same amount of respect.
They're good. Thank you, though. I appreciate that. Again, physician marketing, it really blurs the lines of if we're actually here legitimately in the interest of patients that are concerned. Moving forward, too, we look into the physician recommendations. Our law makes it that it cannot be smoked, so we typically would think that that means that we can't use the raw herbal material. Unfortunately, in the vaporizer pens, you actually can. However, moving forward, with not smoking, we do have the vaporizers, and we do have Sotera here. And when we talk about prior to AD and Christ and what have you, and all of these different years and when legalization in 1800s, et cetera, we're not talking about the same potency that we were talking about back then. Back in 1975, the potency of marijuana was 0.74%, and people were getting high at that time. So now when we're looking at strains that are as high as 84% and higher, we need to be concerned with how is that affecting individuals' brains, their abilities to make decisions and operate motor vehicles. So the other thing is these dispensaries, although I do agree that they should be professional looking, et cetera, the difficulty is it's not a pharmacy. They're not having a pharmacist there or a pharmacist tech that has gone to school for the 4 years, 2,000 hours of an internship, et cetera, et cetera. They're making guesses on what someone should be taking, how much they should be taking. There isn't a dose, there isn't when to take it, how to take it, and any contraindications with any medications that they may already be having. Here's another advertisement for another highly potent, high THC. Again, I understand that you guys are 5 and below. This is just something to keep in mind of what is coming and can be coming and what we are seeing in Florida. We have True Leave, again, shatter. If you look up some of these terms, shatter, wax, dabbing, etc. In fact, I actually urge you to go to YouTube at some point and look up Custom Grow 420. What's interesting about this individual is pretty much in every one of his videos, he puts the disclaimer out there that he is a medical Prop 64 patient. So he's already putting it out there that I am a medical patient, yet all of his videos utilizing shatter, etc., he is getting completely stoned, and he is experiencing some unbelievable side effects. Please look him up just to see and understand what these different products are. When we look at the Poison Center data, and I know I'm probably going over as well, we look at Poison Center data, we look at decriminalization, which this is actually part of decriminalization. We look at the increase in accidental ingestions of some of the marijuana products. Attributing to that is products such as these. We have made sure that these are not available in the state of Florida. These, if you do notice, do say medical use only. They're candies, they're cookies, they're brownies, they're all sorts of different things. I would urge you to do the same and make sure that we don't have these types of products, or you don't have these types of products here in Georgia, because they are being miseaten. And as the individual was saying earlier, I'm very sorry, I don't remember your name, was talking about how when you ingest it, the effect doesn't come on until later, et cetera, et cetera. Many bad things are happening to children and adults with these. So that's something to look into. Along with that comes the labeling and the packaging. Colorado had to go in and change its packaging and change how things are labeled so that it was tamper-proof. Kids weren't able to get into it. They weren't able to see into them to see what they actually were, and it was a little bit more discreet and more professional in that sense. This again goes into the exposures. I know you all have your slides in front of you. You can see these. I'm sure they can be, I'm sure they're up for. And I'm sorry, I know I have like a 10-minute time limit, so I'm trying to move as quickly as I can. Cultivation and dispensaries.
Spencer, hang on one second.
Yes, sir.
The slides are going to be available on the website, so everybody can go get those. Sorry if you can't see them now, but they will be available. So.
And I was told we had a 10-minute time limit, so I'm desperately trying to keep on that in an effort to make sure that we get everything through on the agenda. So I know what was interesting to you all and that you were going to be looking at was your cultivation and your dispensaries. Florida is interesting in the sense that we have these different licenses that are given out, and they actually, with those licenses, you're allowed to have the cultivation, the manufacturing, and also dispensaries, although the dispensaries are not supposed to be connected to. However, they are usually in very close proximity. There's certain numbers of these. Here is an example of what one of the facilities looks like in the Apollo Beach area. It's 150,000 square feet. These are not zoned in the sense that these can be right next to neighborhoods. In fact, Certera, prior to our amendment passing and our low THC in Florida, they were right next to a home. And there was a playground right there, et cetera. So you may want to look into zoning and seeing where and how close and in what proximity. Our dispensaries, the only zoning that we have is actually 500 feet from a school, and they're actually also zoned as a pharmacy would be in a strip mall. You may consider going further out, more like your liquor establishments in most states are about 1,500 feet or further. You may look into that, again, going into commercialization and marketing, which also will go into what your signage, what you're going to allow for your signage and what language you are going to allow. I know you were talking about the nuances in language. What language will you have on your signage? What kind of perception will be put out there? The other thing, this is just another sign of the place. It doesn't even actually identify what it is. It still keeps the old sign up there that it's a vegetable company. What you may also want to look at with your cultivation and your companies, and it was interesting too, you mentioned about companies coming in that are just interested in making money, and that's certainly the case. What we have seen in Florida is each one of the individuals that have the licenses are being bought up or were already financed by companies that were from out of state. We obviously have Certera, which is based in Georgia. We have several companies that are actually out of the country that are backing financially our grows and the dispensaries. We have some from Delaware. I have some of them listed in here, Massachusetts, MedMen out of California. So if Georgia is interested in this, you may want to look into who is actually funding, and if you're going to put regulations on that to keep it to Georgia so that you know that Georgia people are really interested in taking care of Georgia people. Again, this is just what's going on inside. You've seen a couple of these types of images in the previous presentation of what it looks like in the facilities with the marijuana. and then the different processes for making the oils, etc. Again, we go back to potency. The other issue, I do appreciate that you have a list of conditions. I think that's a great place to start. It's fantastic. Maybe if you didn't already have one, another thing to look at, which we were going to look at with our physicians, is having some sort of regulatory committee, agency looking at from all angles, like you said, different sides, et cetera, looking at all the information before you decide if there is another condition that you are going to add, et cetera. Ours, the reason why it's a concern for us, the way ours was written, is the last one in our amendment allowed for any symptom of the aforementioned conditions would qualify. Basically, that's de facto legalization. I can walk into and I can talk about any symptom that I have would fall under one of the conditions that was already listed. Something to think about moving forward, again, in the interest of making sure that you are protecting your constituents and the individuals that need or may not need the assistance. Some more information about the dispensaries. I don't know if you guys have considered looking into what the population is for a particular area. We looked at it from the fiscal department. They decide, if you've got a denser population, et cetera, that may be something that Georgia looks into to decide how many are you going to allow, et cetera. I'm over time. I apologize. I went as quickly as I could, but I know you have it in front of you, and I know it will be available for those in the audience that need to see it as well. So thank you for your time. Sure.
Question, please.
Yes, ma'am.
You talked about the doctors using Skype.
Yeah, prior to.
Do you think there would be a role for legitimate telemedicine, especially in the rural areas and for the children?
Perhaps after they've already seen a physician, but you cannot test. There are certain physical tests that you are not able to conduct through a screen. So certainly there is a place for telemedicine. I know we're moving more forward in that arena when we have emergencies, et cetera, or maybe a common cold that we have at home that we just need to see a doctor. And even for my area, which is clinician, if we are going to have a one-on-one session with someone therapeutically, but no, you need to have that patient physically in front of you to go through everything. But there certainly is opportunity to move forward looking into that because things are always changing.
And then one second question. Do you think it would be useful if there was a pharmacist in the dispensaries?
I think it could potentially be useful. I think more importantly what the point is that these are not FDA-approved medications, and we can bemoan the FDA all day long, but the bottom line is at the end of the day their job is to provide safe and effective medications. With that, we also know what the contraindications are, we also know what potential side effects are, et cetera, et cetera. We know exactly what chemicals are in those medications. That pharmacist knows those chemicals. When we start talking about a plant that has well over 400 to 500 to 600 chemicals, depending on who you want to talk to, we don't know. And so I certainly think it would be helpful to have either a chemist or a pharmacist there, and we do know that many chemists are actually behind the scenes making and working with these plants. But again, the point is we do not know side effects, contraindications, strains change from day to day. We also know that the THC and the CBT content changes depending on the time of the day that you clip from the plant. So there's all sorts of different variances and variables that are concerning that. It would be helpful if we had someone or we had a better way to know. And the only way to do that is through rigorous testing. Anything
All
else?
right. Couple things. One statement. You had mentioned kind of having a medical board make recommendations as to add a. That's actually part of this bill.
Awesome.
HB 65. The
Very
medical
cool.
examining board will make those recommendations
That'll
to
help
the
you
legislature,
tremendously.
which still will. We still would vote on whether to add or take something
Awesome.
away. So
Great job. That's great.
that has been taken care of. I want to go back to kind of a follow-up on Susan's question, going back to the telemedicine. Does a doctor really have to sit there to be able to diagnose an illness? I mean, do they always have to be physically present? Because in our case, the way the law is written, the doctors aren't actually prescribing the oil, and they're not actually dosing the oil, so would they actually need to be there? Or, I'm just kind of, and that even kind of applies to the to your recommendation on the training for the doctors. They're just making the diagnosis. That's all they're doing.
Right.
And then signing off, and then our DPH is who actually approves or does not approve the person or the patient receiving the medical marijuana card.
So then a question to that would be, and you're right, they're not prescribing, they're actually recommending because it's not a prescription. So the question to that would be, am I simply taking my diagnosis from a physician and walking into a store? Or
No, our law requires them to then apply through DPH, who will then
Right.
approve or not approve them getting a medical marijuana card.
so I can do that with or without my doctor knowing.
The doctor signs off on the diagnosis.
On the diagnosis.
Right.
But
so
do
you
they-
so your doctor is either going to sign off that you have seizures or you have MS or you have Crohn's disease, and the list is, A through Q. The doctor makes that determination. Then the department is actually who
Right.
will get in and look at, does this person require that?
So the one piece
Or
that
not.
we have that I'm not hearing you say, and I don't know if you do or do not have it, is our doctors are then required to register that with the state. So then they know, and the dispensary knows if that patient received that diagnosis. The doctor will also know if that patient received that medication. Because at that point, my concern, and why I'm asking you that, is you shouldn't be taking alcohol with certain medications. So thus, you shouldn't be taking cannabis, marijuana, et cetera, with other medications. So if your doctor does not know what you're taking, it's helpful for them to have a registry in place that they can actually go in and look and see what you've been taking, what you purchased, et cetera. Does that answer make sense?
I mean, you're asking what if questions, but we're building this from the ground up. I mean, we don't have dispensaries. We don't.
Right.
None of this is in place. All we have is a law that says you can have this oil.
Right.
So we're trying to learn.
So-
and we're trying to learn to
and
do it
that's-
the right way.
And that's what I would do, that I would look into putting some mechanism in place that they had a registry, like we have the marijuana registry. So they have to report that to that within 7 days. Same thing on the other end, it needs to be reported when they've purchased an item, et cetera. That way you can track and make sure, and your doctor knows. That way, to that question, maybe your initial appointment is face-to-face. Maybe your follow-up appointments are through telemedicine, but at least they have a mechanism in place that they know what other prescriptions you're taking and, in fact, if you're utilizing that.
Okay, fair enough.
Sir?
Dale?
Yes, Dr. Spencer, thank you very much for
No, thank you.
coming. A lot of questions. I'll keep it very brief.
Okay.
One, I would, the telecommunication, so forth, I think that's extremely important
Yeah.
as to do, especially when you look at transporting a special needs child
Absolutely.
across the state.
Yep. For
Because
sure.
but for the most part, though, 90% of the problems or concerns that you addressed seem to come from the simple fact that we don't currently have a legal way for patients to access oil. We would love to have most of the problems you described
Right.
with having dispensaries and so forth. But and I know it's very tempting to talk about things like shatter, and we've heard that word quite a bit. But as someone who has, collected a little bit of shatter and had to smuggle it back on an airplane and risk being arrested in Atlanta, to me, that everybody's going to take a law that whatever we create, and they're going to potentially abuse it.
Right.
But shatter's not legal. So we're not here to talk about shatter today.
Good.
Shatter creates medicine. You break shatter down, and it makes a whole bunch of bottles of medicine. So, I mean, I don't think that's something we should be scared about, because it takes a whole bunch of concentrate to make a whole bunch of bottles of oil that are medicine for my child, which I have
Shatter
done.
actually goes one step further, though. That's the thing. You didn't even have to take it to shatter. It could have stopped at the oil.
Well, if we had a legal way to access it and cultivate it and process it here in the state of Georgia, I would tend to agree with you.
Which is why I'm excited that you
Right.
guys are having this hearing and figuring it all out.
And I would end with saying that I would have to strongly recommend that you look into your facts about the opioid deaths.
I have.
And
Thank
them
you.
increasing or decreasing. Thank you.
I have. Thank you.
And, taking all of the recommendations, taking what we've several times on the committee during our working lunches is what we're trying to do is take best practices.
Absolutely.
From around the different states. We're trying to learn from some other states that maybe started early, seeing some of the roadblocks or some of the problems that they've run into so that we can not do that here in Georgia.
Exactly.
Do you think that's possible? If we were diligent on this committee, we were looking at these other states, making sure that we had a good, safe product so that our citizens could access it with these diagnoses. If the medical board in the future decides to add another one, maybe we see one being taken off in the future. Either way, is it possible in your mind that this can be achieved in states if they really roll their sleeves up to take it from a very serious approach for their citizens?
I think that's the biggest point, and that's the main point, is to make sure that you look at everything and also don't back yourselves into corners, because sometimes we write ourselves legislatively into a corner that we can't get ourselves out of, such as with loopholes. There's different loopholes in figuring out and very cautiously and very carefully looking at what's going to be in the best interest of our state 20 years down from now, and educating yourselves, which is exactly what you're doing, from what's going on in other states. I certainly think it's possible. I mean, I think it's crazy to think this isn't going to happen, I'm going to stop HB 65. The pony already left the stable. How can we work together to make it safe and best practice for everyone? Prime example, you don't have to have shatter. For your medicine, it would be way before then. So it's understanding the different nuances in the different products that are available or not available that you do or do not want in your state. So no, I think I commend the commission. I think you're doing an amazing job. This is exactly what you should be doing, and this is how you get stuff done. Thank you. No, you're very welcome. Thank you. Okay, awesome. Thank you, guys.
Again, Reverend, we got to maintain proper decorum. Next up, we're going to hear from Justin Kernan, who is the Senior Government Relations for the Georgia Municipal Association, to talk about other states' local government regulations and excise tax. Justin, thank you for being here today.
Thank you for having me. Mr. Chairman. All right, well, thank you for allowing us to present today, and we're going to just briefly talk about some of the various states and how they have taxed medicinal marijuana. I'm going to be very brief. I will try not to go over my 10-minute time limit. A week ago, Georgia Municipal Association was not engaged on this topic at all. It wasn't until the great Senator Brad showed up at the law enforcement task force in which we started to take a look at this as different ways to increase funding for things like law enforcement, and then we started looking at some of the other states and what they were doing and how it was impacting some states across the country, and we decided that we were going to start taking a look at it, but we do not have a policy position currently on medicinal marijuana. I'm just going to be presenting some research and data findings during this brief presentation. This shall not serve as any recommendations from the Georgia Municipal Association. However, if this committee is going to move forward and is looking for some recommendations, we would like some more time to further research this topic and see how these numbers match up and what's a really good fit for the state of Georgia. So right now I'll just be providing a snapshot of what some of the other states are doing. And please excuse there's a typo on here. It's not 18 states that have passed legislation. It's closer. It's 23, and that number can vary. Like Georgia has passed some type of legislation, but all of the details have not been codified, and there's a couple of other states like that as well. Allowing patients to utilize solely medical marijuana, and 14 of those states are looking at or allowing some form of taxation through sales tax, excise tax, or some other type of use tax. And so when we look at sales taxes and excise taxes, there are a couple of different ways that you can approach it. There are a couple of states that chose to not tax medicinal marijuana at all. And some of those are because the states do not have a state sales or retail tax in place in general, and then some of them use their prescription drug exemptions and apply them to medicinal marijuana as well. So when you look at some of the states, some do a state and local tax, and then some just do excise tax. So I'll briefly walk through what we have here. And Arizona allows for a state tax of 6.6%, and then also a local sales tax of 2 to 3%, depending on that municipality. In Arizona's case, I get to use our favorite word, which is local control, in which municipalities have the distinction and the ability and flexibility to decide which one they're going to use, whether it's a 2% or 3% local sales tax on those products. Arkansas has both a sales tax and an excise tax. They have a state sales tax at 6.5% and a local sales tax up to 3.5%. It can go fractionally, I think, starting at 0.5 and all the way up to 3.5%. Arkansas also has an excise tax that they call a special privilege tax that they tax at an additional 4%. Connecticut has a state tax at 6.25. Illinois is one of the states that have both as well. They have a 1% sales tax, and their Illinois' tax structure is very complicated, go figure. And it's 1% up into a certain time frame, and then it's scheduled to change. However, their privilege tax is set at that 7%. Louisiana also has a local and a state sales tax. The local sales tax piece has not been determined yet. That's not in the code. In the code, it allows for locals to collect sales tax, but that number has not been set yet. Michigan, New Jersey, and New Jersey only have sales taxes applied at 6% and 7% respectively. Rhode Island has both. Once again, it has a state sales tax at 7% and then a local excise tax at 4%. Now, all of these different states have all of these different tax structures, and all of them are completely different. And so we would have to take all of these and look at how they're taxed, how they're collected, where the money goes, how all of those funds are allocated, and decide if this commission was going to move forward with a tax recommendation, what's the best fit for Georgia. Because when you look at them, like I said, everyone has a different way of doing it. Some of them allow you to remit it to the state, and then the state distributes it back to the local governments. Others allow the local governments to collect those sales taxes and keep them in their communities. And so there's a lot of different ways in which you can collect those taxes. But I would say if Georgia is going to look at this, allowing a local sales tax or local excise tax on these products, I think would be beneficial. Once again, because local governments can utilize these for different purposes. There's no secret. You watch it on the news and you hear about it all the time. Law enforcement's having problems recruiting and retaining officers, and a lot of it is due to the pay. Local governments, the state increased the pay for law enforcement by 20%. Local governments have not been able to do the same. Some of the local governments that have a larger tax base have been able to pay their law enforcement additional monies. But we are looking at all types of different ways to get the revenue because as of right now, when you look at city, just specifically municipal budgets, most of the time law enforcement is over 50% of that budget, and it can be up to 65%. It just depends on that city. And so having a local sales tax or a local excise tax in place on medicinal marijuana would allow for those local governments to shore up some of their law enforcement funds, especially since the fact that law enforcement, it's the local law enforcement that's going to be responsible for responding to anything or enforcing the regulations that are done by the state. Also having some treatment programs that we're struggling with. The opioid crisis has hit all over the country. Local governments are looking for additional resources to help to combat that. This can help with that as well. Fighting homelessness and blight remediation are also two other things that these local taxes. The state does certain things very well, but these four things that are on the board are things that are best done at the local level. However, we need additional resources to do these things, and we feel that the taxation on these medicinal products can allow us to do these couple of things to the best of our abilities. But the tax rates imposed on medical marijuana sales are not as burdensome as the taxes on recreational marijuana. When you look at states that allow either both or, well, when you look at states that allow both, when you look at the tax structure for the recreational marijuana, they're all over the board, and certain pieces have to go to certain programs and stuff like that. So for this purpose, we specifically looked at states that were only doing medicinal marijuana, and so that's where we came up with this stuff. But then also on the tax structure, I'll go back here, all of these different states have different ways to tax, but they also tax different parts of the process. And so you have some states that have a sales or use tax that only applies to the distributors or the actual centers where people are going to get the products, and then you have some that tax the cultivators, and then some that are allowed that allow that tax to be passed on to the patients. And so Georgia would really have to figure out how that works best for us and who you want to tax in that process. That would also determine the amount of money that that would go into the state and hopefully the local government's coffers based on this, based on who you're allowing to tax. And so I'll just wrap it up there.
Thank you, Justin, for being here. I do have a couple of quick questions. One on the taxation, and you mentioned law enforcement, and I certainly think there's a way to figure that out. How can we guarantee that our local municipalities, that money would go to the law enforcement and not just say to the general fund?
It's a great question. I mean, we can, so in the state, in order for you to earmark that money to a special purpose, you have to have a constitutional amendment that allows for it. On a local level, it doesn't take that. However, we can do, if we have an excise tax on a particular product, so on the medicinal marijuana, you can have it in the code that we have to have an ordinance that allows that money to be collected specifically for that purpose. And then, as you are fully aware, or everybody in this body is fully aware, we get audited all the time. And you can take a look at all of our information, our financials all the time, and you can determine where all of those monies are going. So you can just require it in the law that the ordinance says that the money collected from these excise taxes has to go to public safety purposes or any of the other delineated purposes.
Okay, and then second question, and you may not know the answer to this because I know you are kind of new to the game here, so to speak. So I want to talk about zoning for a little bit. Are y'all aware of any other states that have had any issues with the zoning of, say, a dispensary, or the zoning of the nursery or the whatever?
So you have certain states that don't have zoning. I'm sorry, not necessarily whole states, but you have certain cities that don't have zoning laws, period. And so I don't know that any of them are. When you say issues, it depends on what side of that you're on. But you do have certain cases in which Florida is one of them, in which until that 500 feet buffer is not something that might work out here in Georgia. And so it just depends. I think zoning, and we're open to having conversations about zoning. We would not necessarily want a nursery right next door to a school and things of that nature. And so those are all things that can be put in the state law. We just ask to not be preempted and to have a seat at the table when discussing the zoning.
Right, and I guess my fear is, all right, let's say we go this route and we make a recommendation, and let's say the state passes it, and then every single county comes back, or every single city comes back, in your case, city, would come back and say, well, we don't want a dispensary here, we don't want a nursery here, so here we have a law that, and I'm all for local control. So I guess I'm just trying to figure out that balance.
I think we can just borrow from what's in the existing code. Currently, there's all types of zoning regulations on pawn shops. There's zoning regulations on liquor stores and things of that nature. You can just take all of that stuff and apply it to this as well. You can even go a step further. If you don't think the 1,500 feet buffer is large enough, then you can expand it. But that's something that the state can definitely do. And if you set some basic parameters, then local governments have no choice but to follow it. We just ask to be at the table when discussing what those parameters are. But there are plenty of examples riddled through the Georgia Code on zoning for things of this nature.
Fair enough.
One thing in the zoning is, hopefully you guys will help us look into this, is a lot of times we by default look at it, like you just said, from a liquor store and things like that, but we are focusing on medical marijuana. So could we also look at pharmacy zonings, and then understand why these few states have said no tax as well? And I don't know the answers to any of them, but we'd encourage you, as you help us look through this, to look at it through a number of different lenses, especially since this is medical focused.
Absolutely. We would love to do that. Some of the states don't have taxes because, like Delaware, for instance, Delaware doesn't. They're a tax shelter for certain things. That's what they do, and they decided to expand it. And others, the way that they're allowing no tax on it is because they're considering this a prescribed product, and they don't allow taxes on prescription drugs. And so, but there are different ways to look at it. We'd be glad to continue to have that conversation.
Any other questions? Okay, thank you.
No problem. Thank you for your time.
All right, next on the agenda, we've got Pete Scandalakis. He's Executive Director with the Prosecuting Attorneys Council of Georgia. And Pete's also going to come up and look at other states as well. Thank you, Pete.
Thank you very much, Mr. Chairman. I appreciate the pleasure of being here. Also appreciate y'all having this in Athens. This is my old stomping grounds. I spent 10 years up here going to school, and just so y'all know, that wasn't 10 years just getting an undergraduate degree, okay? Got my master's degree here too, as well as my undergraduate degree and my law degree. My dad was real glad when I ran out of degrees to get, because being an immigrant from Greece, he thought one degree would be good enough, but I loved it here so much I kept coming back. So when I graduated from law school and he was at the ceremony, and he said, "What are you going to do now, son?" I said, "Dad, I'm going to try to find another degree to get." And he about had a heart attack. But I appreciate being here. It's an honor to be here. Appreciate being able to talk to you. There's not a lot I can add to what Neil said. And Neil, I'm sorry I missed your last name. I thought he was very comprehensive, and Dr. Jessica Spencer said a lot too. So one of the things that I have to tell y'all, and I would be remiss if I didn't say this, is we all know that the 800-pound gorilla that's sitting in the room is the federal government. As a lawyer and as a prosecutor for the Prosecuting Attorneys Council, I've got to tell you that, as I told you last time, there's no consensus among the DAs what the position should be on this, and therefore this is a policy issue that the legislature has to set. But we cannot be at a position where we are at odds with the federal government when it comes to what they're going to do. So I hope you understand that. We're here to help. We don't know what the federal government's going to do. We don't know what position they're going to take. I tend to agree with Neil that this thing seems to be having a momentum of its own. We don't know what the FDA is going to do. Obviously, we're talking about medicinal marijuana. We're talking about cannabis oil, which has obviously effects that help people. All of you have heard testimony as to that. There are people in this room who will testify that it helped them. But again, it's one of those things that we don't know what the FDA is going to do because they have sat silent on it. And that's something that I want to make sure you understand, that when I'm talking about helping you achieve your policy, I don't want you to think that somehow I'm taking an advocate's position one way or the other. I did send this morning the committee, we looked at a number of different states that had legislation and had enacted medicinal marijuana. And this morning I sent, Senator Brass, I sent your committee, the secretary for your committee, basically 4 states that we kind of broke it down that were closest to Georgia's issue that we're dealing with here. And you can put that on your website later, and it's something for y'all to read at night as you go through these statutes and you need to get to sleep. It's something that'll help you go to sleep. So that's just the way it is. And I'll just go over the 4 that we think are closest to Georgia, that the 4 you may want to take a closer look at. And then I'll just kind of break that down into bigger areas. We didn't include Florida in that because we knew you were going to have speakers here today talking about Florida, and so we didn't want to cover that again. However, we can make the Florida statute available to you. We'll send that to you as well when you want to see that. But the 4 states we looked at were Iowa, Missouri, Texas, and Virginia. Those are the 4 we broke it down to. It's interesting that Missouri, their manufacturing, their dispensaries are nonprofits. How that works, I don't know. How that works in the tax scheme that Mr. Kernan was talking about, I don't know. But the others were profits. Whether or not you have a vertical manufacturing and dispensary all in the same location is something that this committee is going to have to decide. We don't have, obviously, a position in that. There are advantages to vertical, to have a manufacturer, the process, and the dispensary in one location. Some states do that, some states do not. They require the manufacturer to be separate from the dispensary. However, those states, those 4 states that I talked about, also will allow, if you have a license to manufacture, you can have a license to dispense. It just can't be on the same location. So again, that's something for you to decide. Iowa's interesting. It's about I think about 3, I'm not sure that, I know Georgia's about 3 times bigger than Iowa in population, but they have 2 licenses that they've issued for for manufacturing, and they can have up to 5 dispensaries, and they've divided it among the state. There's 2 places that you can get it now, get the medical cannabis, and they're looking into going to a 3rd facility. So one of the things that you can control is what I mentioned earlier, and when I testified earlier, is you can control the number of licenses you issue, where it's manufactured, how much is manufactured in a certain location, and then how it's dispensed and where you're going to put those dispensaries. I don't think those states, the states we've looked at, it doesn't seem to be that those dispensaries can pop up any place. So how that affects the overall taxing scheme of the state is something that is way above my pay grade, and it's something that y'all would have to look at. Also, each state has a different way to regulate it. Some comes under the Department of Health, some comes under the Department of Agriculture. One comes under Department of Pharmacy, I think, that a state has. And basically the state has taken the position that you come up with the regulations and then you show them to us and we'll decide whether or not we want to accept them or not. So that's another way to do it. And basically is whoever you decide you want to regulate this has to be brought in early on the legislative side. So you can get the regulations down and the administration down about how you want it to be shaped. Every state has laws that have what is called an affirmative defense. That is, if you have a prescription card, and like you were talking about, Senator Brass, and you are picked up by law enforcement, and you have the prescribed amount of cannabis oil, that is an affirmative defense to prosecution. However, if you do not have a prescription card, or if you have a prescription card and you have more than the amount that you're allowed to possess, those are offenses that can go to prosecution should the prosecutor elect to do so. I think that's about it. I can answer any questions, but I think the easiest thing is when you get that handout that I say handout, when you get the email that I sent you this morning, and again, you can put that on your website for each of you to go through that and have the prosecuting attorney's counsel, available to answer those questions, because what we have found through our analysis is each state is struggling and trying to come up with the best way, and as I think, and I'm going to call him Mr. Neal since I can't remember his last name, to protect its citizens, to make sure that it's safeguarding its citizens. Some states, for example, Virginia, outlaw the use of pesticides on any of the manufacturing process, at any stage of the manufacturing process, and you have to have permission by the Department of Agriculture to go in and use a pesticide should you have some type of infestation in your plants. So that's one of the things. Another thing is the states are real careful about who is monitoring the THC level in the cannabis oil. to make sure that we don't have either a diluted amount of THC or we don't have contaminations, which I know Mr. Jackson was concerned about at one point. So, whether or not you have that chemist on site or whether or not you have a chemist that the state pays for that goes to these sites and has inspections to make sure that you're producing the plants you say you're producing with the THC content in your cannabis oil that is being that is supposed to comply with the law, that's something you have to take into consideration. And where that falls under, does it fall under, again, Department of Agriculture, Public Health? How are you going to put that in the state system? There's so many different states for you to pick from, what works and what doesn't work. And one of the things that's hard to tell about what doesn't work is this is all new to a lot of states. A lot of states are taking this on in the last 5 or 6 years. This is not something that has just been out there for a long time that we can study. So I guess that's my testimony in a nutshell. Again, we have all the statutes we can send to you and let you read through them. But until we have specifics on how we're going to regulate it, what we're going to look for, who we're going to issue the licenses to, how many licenses we're going to issue, who's going to make sure that the purity is what the purity says it is. I think, it was Dr. Spencer who talked about the packaging, what you're going to do with the packaging to ensure the safety. Security. All of these agencies, well, let me backtrack. The states that do have regulators also have a provision where the administration of the regulations, you have certified law enforcement officers who are participating and can do site inspections. Now, sometimes they require a 3-day notice that you're going to come do an audit and a site inspection. Some states have it where the law enforcement, when they shows up, you open up the door and they can do the site inspection. So that's it in a nutshell, and I can answer any questions, but really it's what we're talking about is getting down into the details because there are a lot of weeds out there.
No pun intended.
Play on word, okay.
You made a funny.
And I didn't even try to do that.
I guess I got 2 quick questions. One on your inspection and audits. Is that local law enforcement? Some states are they? Is it the local law enforcement, or do they?
Some states allow the local sheriff to do it.
Uh-huh.
Obviously he knows the statute, he knows the background, or she knows the background of the statutes and what he or she's looking for. Some have certified officers inside the regulatory department. So it all depends on how you set it up.
Gotcha. And then I guess my second one is, I guess, a little bit more of a statement than a question, but I know as a prosecutor, and what's the word? Ambiguity,
yes.
Yeah, I went to UGA too, and we didn't work on that word, but I only have 1 degree. So ambiguity.
We were taught not to use big words, but go ahead.
That's right. So that's obviously a bad word in your line of work, and so what we don't want to do is create too much gray area.
Correct.
Because I feel like we're already operating in a gray space. So I look forward to working with you and the council on making sure that whatever recommendations we do make to the legislature, that whatever laws, if any, are created, that we're very clear on what those laws are, what the penalties are going to be, the structure, everything. I mean, like you said, there's so much we've got to do on this.
Absolutely, and I know the Sheriff's Association would like to participate in that, and the Chiefs Association as well. And one of the things I think Neil touched on too is that all of these states have background checks for people who work in the manufacturing, in the process, and the distribution. They are background checks that everybody has to pass. Now, how often you have to go through that process, I don't know, but I do know every state has that down in their statutes of background checks. Who can work in those dispensaries, who cannot work, and what will happen if you have someone who doesn't pass a background check or has violated the law. What might happen to that dispensary if something comes up like that?
Okay, thank you.
Pete, thank you so much. I know it was just the last meeting when you were asked to get this information, and we greatly appreciate your time and jumping on it for the committee.
You're
very much
welcome.
appreciate it. It was Virginia, Iowa, Missouri,
Texas.
Texas.
And as I said, I sent an outline of those statutes to Senator Brass's secretary and asked her to distribute them to the committee
Thank you.
and then to put them on your website if you so choose to do that.
Thank you. And this is not I don't want you to make an endorsement. I don't want you to do, of those states, did one stick out more than the other one to you of having, hey, that looks like they may be onto something over there that's a good system?
We kind of, and this is when I say we, I discuss this with the lawyers in my office, and Gilbert Crosby, who's right there, he was one of the lead people doing the research in this. We kind of looked at Iowa, and Iowa seems to be closest to what you're trying to accomplish here in Georgia. And that's the one that we kind of looked at, and they were further along in their regulations than some other states. Thank y'all so much. I appreciate y'all.
Okay, our next presenter is Wesley Dunn, who is an attorney at law to talk about other states' integration process and other states and what they're doing. Wesley, thank you so much for being here.
Thank you for the invitation. I'd like to follow up with Pete for a minute because I've known him for a long time, and he's been a very thoughtful and sincere prosecutor when he was a DA, and he's always been a wonderful person to work with and very reasonable in his approach to everything. My name is Wesley Dunn, as he said. I'm a former member of the Georgia House of Representatives, an attorney and an advocate for medical cannabis. I was introduced to the movement nearly 5 years ago when representing a client who asked me to look into the possibility of Georgia getting to cultivation of medical cannabis. We attended some of the early task force meetings, the governor's first task force on looking at medical cannabis, which in my opinion was stacked to get a directed outcome of having the final outcome be decided not to do it. There, I met Georgians from all walks of life. I met parents with autism. I met parents with some children that had diseases I'd never even heard of before. I've met veterans with PTSD. I've met patients with MS. And during that process, I became a strong advocate. I became friends with many of these people. Many of you today are my friends from those days. Made a mistake becoming personally involved with this issue. I always thought that was not professional in my profession as an attorney. But I'm here today to tell you I'm personally involved. I love these people. They're my friends. And I've committed to do everything in my power to see that they have a safe access to the medicines they so much need. My wife and I, a business partner, are so sincere about this. We've formed an umbrella organization called Safe Access for Everyone, which we hope to use as an advocacy platform for Georgia and nationally. We do work in Washington as well as here in the state. We've been involved in the Farm Bill, and Senator McConnell's amendment started out as a standalone bill. He's amended the Farm Bill, taking hemp out of the definition of Controlled Substance Act for marijuana. And in our opinion, I think Neil was correct when he said probably in the next year to 15 months that will pass. I'm sorry, the hemp will pass this year. It may be December, it could be first of the year. The States Act is one of about 8 or 10 marijuana laws passing through the Congress. I think the one that has the most possibility of passing is the States Act, which simply says that if you have a state marijuana law, then that prevails over federal law as long as people are in compliance with the state law. That seems to be a way to duck the issue for men and women in Congress, but I think that would take care of the problems with the states. Appreciate the invitation and honored to speak on the legal issues we face as a state. My remarks have been taken from personal research, my advocacy experience, as well as my experience as a policy advocate when I was in the legislature. I plan to keep my remarks brief because I know we're on a time constraint, and I've seen Dr. Bradshaw's presentation many times, and that's going to be much more entertaining than anything I got to tell you. I think the first thing we need to talk about is what system of licensing may be the most appropriate for Georgia. Over the last few years we've been watching this, several different ways have been mentioned. One was the university method. I highly suggest we don't get into that. The states that have tried that found out very quickly that the universities don't want to do it. Number one, most universities get grants from the federal government. Those contracts require a provision in the contract that says they're not in violation of any federal law. Of course, they are in violation of the Controlled Substance Act as it stands today. Another method has been the nonprofit method. I don't see much different in that than the private method, because you can make a lot of money as a nonprofit. A good example there is United Way, where several years ago you may have heard where the executive director was making almost $500,000 a year. So I don't see that there's a whole lot of difference between going nonprofit or profit, and most people are in business to make a profit, and I think we ought to have a business model there. The next consideration would be vertical integration versus a standalone system. We've heard last meeting and early this meeting about the vertical integration system and what the benefits are there, so I'm going to take my remarks out of that side of it, since you've already heard right much of it. The trend today in the states we've looked at is moving away from vertical integration into a standalone system. Some states use both, and that's certainly a policy consideration that this commission is going to have to make and be debated in the legislature this year. Mandated vertical integration has some benefits, but I believe the drawbacks outweigh any perceived benefits, particularly as it restricts lack of economic development throughout the state. We ran into this issue when the casino bill was being considered. Although the bill restricted to 2 locations, and a lot of the legislators I talked to said they didn't have any problem with it, but they didn't think one location or another should be limited to having the economic benefit, that their community ought to have the same benefit as anybody else if they chose to. So I would say standalone may be a good way to do, because it does spread the benefit to the people. And I think most people are excited about this industry, because they perceive that there's a benefit in it economically for them to some extent. Another disadvantage is potential lack of specialization. Vertical integration requires farmers to also be chemical engineers and retailers, or retailers to also be chemical engineers and retailers. Those are sophisticated skills. By separating each skill into the specialties in each area, you can lead to products of higher quality of the medicine and service to the patients. Standalone licenses should be permitted in each level of the supply chain to people or entities who have required qualifications that you set forth in the legislation that can adequately provide the cultivation, the manufacture, or the dispensing. This opens up the ability to expand the economic benefit of developing the industry across the state, provides farmers in economically depressed areas of our state new resources of revenue, and provides more convenient access to patients across the state. Those who may advocate for mandated vertical integration are trying to limit licenses to a small group of people, and most of which are mostly investment companies that have to go out and hire the resources, the specialists. So by using the standalone system, you have the ability to contract with the licensed people who have specific expertise in the different levels of the licensing of the manufacturing process. Farmers have required the expertise to produce high-quality plant material to be manufactured into low THC oil, and farmers in Georgia, I assure you, can figure out a way to grow a product in their community or region of the state. Anyone questioning security, and I know this is a big issue with law enforcement, most of the laws we have looked at require a fenced facility, indoor facility with commercial locks, 24/7 video surveillance that is kept for a number of days, and certainly this commission can come up with recommendations of how to secure a facility. I don't think that's really the issue that has been made out to be. I would also suggest on the security standpoint, and I hope the law enforcement agree with this, but I think part of the licensing requirement ought to be for the facilities, whether it's cultivation, manufacture, or dispensing, should also register with the sheriff's office in the county where the facilities are going to be located. The client I mentioned earlier, when he first looked at it 5 years ago, had even talked to a sheriff in his county about doing a closed circuit TV feed into the sheriff's office that would have 24/7 coverage there. We're already doing security with transportation. If you had multiple dispensing facilities, even with a vertical structure, the product would have to be transported somewhere. So whatever transportation security is used in this could be used throughout the system if you had a manufacturer that contracted with a grower, because you'd have to process that. There are tracking systems from seed to final product that include documentation of all the plant used, the plant product destroyed, and so you have very sophisticated knowledge of every piece of that product that goes through the system. Of course, I won't go through this licensing considerations because I think Neil covered a lot of things that ought to be included in his remarks earlier, but certainly there ought to be enough licenses to serve the state where people can easily acquire the material. We have one of the biggest states in the country. I think we're the 8th or 9th largest geographically. It's a huge state. I think consideration needs to be given to geographical disbursement of facilities, especially dispensing facilities, because folks that need this medicine, have the cards, need to have access to it. If we have a dispensary in Atlanta, Savannah, Columbus, Augusta, Rome, there are a lot of people going to be left out. So I think there needs to be some consideration on dispensaries of how to distribute a dispensary closer to the population than, in remote locations like that would not reach everybody. I don't think pharmacies would do it, but ultimately I think this medicine should be able to be obtained through a pharmacy. Pharmacies have their own problems with federal law about dealing with illegal substances, and until the feds do something about it, that wouldn't be reasonable. But I know that there's a lot of nutrition-type companies, like we heard from in the last meeting, that with the proper guidance from the legislature and requirements for that licensing and security of the product would be acceptable. I visited the center in Atlanta from the lady or the gentleman who presented at the last meeting, I think it was DNC, and saw their display that's under lock and key. They have about 4 products, which is another thing I think we need to look at, is these dispensaries being able to handle other manufacturers' products. I think most people don't know, I think most of you on this commission do know that there's not one medical cannabis. There's not one 5% medical cannabis. It's different combinations of THC to CBD. You could have a 5% THC and 5% CBD, but you could also have a 3% THC and a 15% CBD. So different products and different combinations of those ratios actually cover different conditions, and so that dispensaries ought to be able to handle product from different manufacturers so that they have the widest availability for what actual people might need as far as their the medicine they've been prescribed. Another thing I think is important is looking at what agency you want to look over this. Like Pete said, some states have 3. Other states have 1. Some states have agriculture included. And I think probably eventually you're going to need agriculture. But politically, one of the things I looked at when I've been working on this is right now, Agriculture Commission doesn't want to have anything to do with it as long as it's on the Controlled Substances Act. So that's a no-starter. They do have the positions. They will enforce any law that you provide, but things like inspecting facilities and other things like that, they don't want to get their hands on right now. So I think the inspections that have been mentioned, most legislations call for inspections. Most laws call for third-party testing so that you can tell you're not taking that information from manufacturers without having it tested. There probably ought to be some additional protocols there to make sure that the product is not adulterated after it's tested, so that you've got to know that the purity of that product is there. Pesticides, okay, let me get back to this. What agency? Right now, I would say public safety public health is the best place to put it because they have the broadest range of expertise in what we're talking about and have the ability to more easily add conditions. In House Bill 65 that established this commission, the Composite Board of Medicine was designated to add conditions. If you look at the purpose in their mission statement on the website, it says purpose, the Georgia Composite Medical Board is an agency that licenses physicians, physician assistants, respiratory care professionals, perfusionists, acupuncturists, et cetera, et cetera, et cetera. The board investigates, complaint, and disciplines those who have violated the Medical Practice Act or other laws governing the professional behavior. Mission statement. Mission of the Georgia Composite Medical Board is to protect the health of Georgians through the proper licensing of physicians, certain members of the healing arts through objective enforcement of the Medical Practice Act. That all deals with licensing of the people. It does not deal necessarily with the expertise in determining or evaluating different conditions and the effect of medical cannabis on those conditions. So I would strongly urge you guys to consolidate all of that under just the Department of Public Health. Other issues that you're going to face, and I'm certainly can't cover everything in 10 minutes, but evolving issues that some were covered in previous legislation, some are just getting to be covered, is zero tolerance workplaces. My guess is that the Chamber of Commerce is going to get involved in this one. But initially, there was no mention of it at all, or it was prohibited to use the medicine in the workplace in a zero tolerance area. Most recent statutes and companies or states have just come on, like Illinois, Connecticut, Massachusetts, provide that you can use medical cannabis if you have been prescribed and have your card, so long as it does not impair your you're not impaired by the drug you're taking. And much of the medical cannabis doesn't have enough THC in it to actually impair you. But I think the best route to go there would be to treat this as any other prescription medicine in the workplace. And they have the same issue in drug-free school zones. And this issue just popped up in some of the meetings last year in the legislature. I think Alan Peake held a meeting of his committee specifically on this, and I think that the medical cannabis ought to be treated as a prescription drug in school zones as well, so that I think the procedure now in most schools that have nurses, they take your medication to the nurse, and at prescribed times the nurse administers the medication to you. What's happening now is a lot of parents having to leave work, come pick up their child, take them off the school property and bring them back. A lot of folks can't do that, which means that they are either child's not going to be in school or the medication is going to wear off sometime in school. And with an autistic child, Dale, I think you know exactly what that might mean. There have been changes. There have been states that have had court cases that denied parents custody of children because they used it. Most recent trend is toward having some protection for parents in that situation where they have a card and have been prescribed the medicine so it doesn't affect the custodial rights. Been issues in early legislation where this was not covered, that people who want to rent housing have been denied a lease because they were using medical cannabis. Enforceability of contracts is something probably nobody but a lawyer would think about, but there's a well-standing proposition in contract law that you can't have a contract, enforceable contract for an illegal purpose. Right now, under the Controlled Substance Act, that's illegal. So are contracts valid in the business? Most of the new legislation is adding to the, putting a stipulation in the legislation that says these contracts are legal. The gentleman from the Municipal Association brought up some issues with taxation. Any license fees, taxation, any of those things are going to add to the ultimate cost of the medicine. So I think one of the things you have to keep in mind as you're sorting through all these policy issues is what can we do to make this product reasonably priced for the folks out there. Some states recently have set up a policy where they are providing a procedure or policy where if you have a financial hardship that's described in the legislation, there is some help either from a joint effort between the state and the manufacturer to provide a certain amount of low low-cost product. But there's several different ways to look at that. And I think I'm about out of time, so I'll save the rest of the time to answer any questions. Reciprocity between states is another one that's popping up, and I think that would be a great thing if our citizens had a card, they could go to another state. You'd probably have to comply with the state law where you're going, but and the same people coming here, they'd have to comply with our law. But I think reciprocity is a trend that we should look at. Any questions?
No questions. I think you covered it all. Thank you, Wesley.
Here we go. Wesley, thank you so much. A final presentation today, Dr. David Bradford, who is an economist here at the University of Georgia. He's going to be talking about opioid, Medicaid, Medicare data from other states and trends that are happening since the creation of medical cannabis legislation.
Absolutely. Thank you for the invitation to speak today. And as the last presentation, welcome to the University of Georgia. We're glad to have you all here. You may know that it's homecoming tomorrow, so hopefully some of you get to stay in town and enjoy the festivities.
Did you say study or stay?
Both, yeah. I, of course, would always encourage you to study, right? But, and so what I've been asked to do today is to go over a little bit of the evidence that we can draw, that we've been drawing here, and actually a research team at the University of Georgia, to try to understand how other states have been impacted by medical cannabis laws, and what we might infer from this sort of peer-reviewed national literature, and we're going to be looking at all the states collectively in a statistical sense, what we might infer about policy decisions here in Georgia. I'm going to go through some of this stuff a little bit more quickly now that I've seen all the other presentations. Some of it's been covered before. There's no point in belaboring the issues. So my hopes for today is that to talk a little bit about the policy context, particularly what we can know about Georgia's style of medical cannabis law compared to other states' styles of medical cannabis law, what we've seen in the literature, the peer-reviewed published literature, in terms of what spillover effects there might be, and focus in a little bit on how medical cannabis interacts with particularly the prescription use of opioid and other pain medications, which is an area that we might be able to have kill two birds with one stone, unfortunate metaphor, I suppose, but where we might be able to actually take care of two problems potentially at the same time. Talk a little bit about the specific findings for Georgia. So just let me briefly go over policy history and point out to you that, as it's been mentioned just a minute ago, cannabis is a Schedule I drug under the Controlled Substances Act. That has a lot of implications. One of the implications is that it's very difficult to do research on when you're trying to do sort of the sorts of randomized clinical trials that we really need to understand the dose response treatment effects for cannabis for the different clinical conditions that we have hopes that cannabis will be effective for. According to the Controlled Substances Act, for a drug to be on the Schedule I, it's got to have a strong potential for abuse, and actually the clinical evidence to date suggests that cannabis has a much lower likelihood of abuse than other illegal drugs like alcohol and tobacco, for example, and in particular that it have no currently accepted medical use. I mentioned this merely to point out, as I'm going to do in just a second, that that last criteria for the Controlled Substances Act is no longer met. But let me also point out to you that that the history of this is that there are 31 states and the District of Columbia today that have approved medical cannabis laws in terms of access to whole plant botanical cannabis, which is not the way that we're moving forward in Georgia. There are 15 states that have approved a Georgia-style cannabis extract law. And if you're looking at the times trend of this, if you look at the top graph that I have here, the blue bars represent the number of states that adopted cannabis policies for whole plant cannabis in each year. The red bars represent the states that have adopted, Georgia's one of them, 2010, 2015, extract laws. One of the unfortunate things that I have to say to the committee is that we don't actually have peer-reviewed evidence on the extract laws yet. So we're going to have to interpolate and extrapolate a little bit from the evidence that we have on whole plant laws. We just haven't had enough time to collect the data and to know what the experience has been. But, hopefully we'll have comparable kinds of experiences. Also, the extract laws, like Georgia's, oftentimes are rolled out in ways that they don't take off quite as quickly as whole plant laws do. It's just a little harder to get the distribution. And so we'll get evidence for that, but it's just not really available at the moment. All right, so one other development to mention before I jump into what the evidence is that in January of 2017, the National Institutes of Sciences, Engineering, and Medicine, the authoritative voice for issues of science in the U.S. and indeed in the world, published a comprehensive review of the clinical literature. They reviewed between 10,000 and 15,000 peer-reviewed English language articles looking at the impact of medical cannabis, and were able to come to some conclusions about what benefits there are. And with regard to things like chronic pain, nausea for chemotherapy, and spasticity symptoms, they found that there was conclusive evidence of a benefit. And so that first criteria that the Controlled Substances Act requires, a necessary condition for Schedule I, is no longer met. And so as we think about where we're going at the federal level, particularly for a policy, medical cannabis is supported by about 90%, 95 or 93% of Americans, depending upon the survey. Nationwide, that's 95% of Democrats and 89% of Republicans. There really doesn't seem like there's much stomach for maintaining a Schedule I status in the long term. So I do think that we'll be able to move forward with a bit more confidence. There's also moderate evidence for a host of other issues as well. And so we do see that there's reason to suspect that these clinical applications are useful and indeed are widely accepted in the clinical community now. So very quickly, what do we worry about in terms of approving these medical cannabis laws affecting other things? Well, we actually see that in the peer-reviewed literature to date, traffic fatalities, traffic accidents actually fall in states with medical cannabis laws in place. This is probably, though I'm speculating a little bit, probably because there's not a culture of a bar where you go to consume cannabis like you would alcohol. And so what we're doing is, if we're shifting consumption from alcohol to cannabis, part of what we're doing is shifting consumption from a bar setting where you drive home into a home setting. And so the potential for accidents goes down. If we get public consumption, that evidence might not hold up over time. We see benefits in terms of reductions in suicides. We don't see any increase in underage drinking. Indeed, underage consumption of cannabis for recreational purposes has been steadily going down, and it continues to go down even in states that have approved medical cannabis laws. So we don't see much stimulation of underage illicit use of cannabis. We don't see criminal offenses going up. It's not, everything is of course not positive. There is some evidence that there are increased cannabis arrests for men in states that have a medical cannabis law in place. And indeed, we do see some early evidence in the early states that there was diversion from medical uses to non-medical uses. So we definitely want to be paying attention to that as we're designing our policies here in Georgia. So let me briefly talk to you about what we're finding in our research here at the University of Georgia on this subject. The primary question that we've been asking as a team, and this is a team of myself and Ashley Bradford, and then two other faculty here at the university, Amanda Abraham and Grace Adams. We've been asking, can we see evidence that people are reacting to cannabis availability as if it were medicine? Again, this is going to be botanical cannabis. We're going to have to, in some sense, hope until the evidence comes in that the same kind of things will hold true for extracts. So we don't have data on people's prescription drug use and their cannabis use. That data sadly doesn't exist. So we're going to try to infer what we can from changes in prescription drug use. For example, do we see fewer pain medications when states turn on medical cannabis? And actually, Ashley and I did the first study, shockingly, on this question. We were very surprised this hadn't been done when we did this. This was published in 2016 in the journal Health Affairs. And what we did was we looked at all prescriptions written under Medicare Part D from 2010 to 2013 and compared that to states that had access to medical cannabis. Those states compared to states that didn't have access. What happened when states turned on medical cannabis laws? Does implementing an effective medical cannabis law, by that we meant, is it possible for patients to get access to cannabis? It would be no good to say, oh, we've got a dispensary-based program, but we have no dispensaries. The law is actually not effective at that point. We only coded laws as being effective when patients could get access. All right? We're ultimately going to ask, does the kind of distribution method matter? And I think this is something we can learn from in Georgia. Is dispensary okay? I mean, should we think about dispensaries versus, in this case, home cultivation, or a more informal system as we currently have here in Georgia? And how does it play out in Medicare and Medicaid? So our first study looked, we looked at, ultimately, over time, we're going to look at 2010 to 2015. We did some statistical analyses. I won't bore you with that, even though, of course, that's the part I get super excited about. But we looked at prescription drugs, all Medicare prescription drugs, across 9 categories. And all you need to know here is that if you see any of these little lines crossing that vertical red line, that means there's no effect. So what you can see is that for 7 of our 9 disease categories, there was a substantial reduction in prescription use for things like anxiety and depression, nausea and pain, and sleep disorders when medical cannabis becomes available. The biggest one is pain medications, big reductions in pain medications when states allow medical cannabis access. We extended that, and this paper is actually coming out. It's been accepted at the Journal of Law and Economics. It'll be coming out soon. We extended it to a couple of years, and we took a look at dispensary versus home cultivation and the setting, rural versus urban. And this is a big lesson, I think, for us. Dispensary-based distribution of cannabis had more than twice the effect at reducing the utilization of pain medications than home cultivation-based effect. And crucially for Georgia, we found all the effect was centered in urban counties, and almost no effect were in rural counties. Note that dispensaries are almost always located in urban settings. So as we're thinking about, are we going to have dispensary-based distribution, we need to also be aware of finding some way to incentivize dispensaries to be opening in the rural areas of the state, because we're finding states that aren't paying attention to that aren't getting benefits for their rural residents. What does it matter? I sometimes hesitate to put this up, but we think that the states that actually changed the law for Medicare, reduced the Medicare program nationally saw between a $420 and a $620 million reduction in expenditures for Medicare Part D. We estimate that if every state had turned on a dispensary-based medical cannabis law, Medicare would have saved somewhere in the neighborhood of $1.5 billion by 2015. Now, that's money shifted to the enrollees who are paying for cannabis presumably out of pocket, but nonetheless, that is a programmatic savings. Quickly, we redid the analysis in Medicaid, and we found essentially the same thing. Pain medications, big reductions, about a 10% reduction in pain medications. Now, and for us, that means for Medicaid, we're talking about a combined reduction in expenditures from actual policies, not just assuming everybody adopts, of about $475 million. If every state had adopted, it'd be about $1 billion for Medicaid. What does this mean for Georgia? Ultimately, going down to the bottom line for Georgia, because we only looked at fee-for-service, if you consider fee-for-service and managed care, Georgia would have probably in 2014 saved about $36 million if we'd had dispensary-based cannabis laws in effect and fully penetrated out into the clinical community. Now, the big question that everybody's interested in is, what about opiates? We redid this analysis looking at opiate prescriptions, in particular in Medicare Part D. And you can't read these numbers, even I can't read these numbers from here, but let me just say the bottom line is that when you when you allow for dispensary-based distribution of medical cannabis, we get about a 14.5% reduction in opiates that are distributed through Medicare. Most of that hydrocodone and morphine related. Finally, can this help us? Oh, and by the way, I should say, if I could argue with a prior witness, there's no evidence that I'm familiar with that suggests anywhere that opiate prescriptions go up when medical cannabis laws go into effect. Every piece of evidence exists to the contrary of that. Finally, the thing that you might ultimately care about, what about opiate mortality? Here's just a general trend nationally from 2000 to 2016. Notice the blue line is rural counties, and rural counties are really suffering today and suffering at an accelerating rate where metropolitan counties are actually seeing a bit of a reduction in opiate mortality. So for our rural residents, we really need to worry about this. What's it mean for Georgia? Here's Georgia mortality rates per 100,000 in 2000. Here's Georgia opiate mortality rates per 100,000 in 2016, the year, the most recent data we have. When states, and again, I'm going to give you all of the research that exists in the peer-reviewed literature on that. There are two major studies that have been done, both published in the best journals, this one in the Journal of the American Medical Association, Internal Medicine, by Marcus Bachhuber and colleagues, that found about a 20 to 25% reduction in opiate mortality in states that turned on medical cannabis laws. And this was replicated on a completely different data set with new and completely different, newer data and different data by Powell, Pakula, and Jacobson very recently. This came out in 2018, and you can't read the numbers, but they found a 25% reduction in opioid mortality as well. I know no clinical evidence, no peer-reviewed literature that suggests opiate mortality goes up when medical cannabis gets turned on. That just simply, to my knowledge, doesn't exist. So what do we find? We find that states are moving forward. More than 2/3 of the U.S. population currently lives with access to whole plant medical cannabis. It's nearly 100% if you think about states that have extract laws, because there's only 3 or 4 states that don't have one of those two available now. The best guidance we have from the National Academies of Sciences says that there's clinical benefit. We find, in fact, that it diverts people away from pain medications, and most importantly, it diverts people away from opiate use. And others have found that, in fact, we see reductions in opiate mortalities. And so one of the things that I think we can say as a research team here at the University of Georgia is that when you appropriately design your medical cannabis laws, you can save lives and money. So I'm excited to hear that we're moving forward with trying to refine the laws that we have here, and I did go over. I apologize for that. I talked as quickly as I could for somebody from Mississippi, but I'll answer any questions you guys have now, if there are any.
I mean, that was fascinating, to be honest.
Thank you. And quick.
I might have learned more if I had you as a professor when I was here. But
actually, I have one of my students out here from a class, undergraduate, a couple years ago, who took a class on this topic with me, and hopefully she enjoyed it.
I mean, you covered so much in a short time. You mentioned that opioid deaths are going down.
Yes.
Is there evidence that, and I think I already know the answer to this, but I'm going to ask it anyway. Are we seeing any evidence of deaths due to cannabis rising?
Well, I mean, it's not possible to. One of the benefits of cannabis over an opioid is that your sort of endogenous cannabinoid system is nowhere near the centers of your brain that control respiration in your heart. So it's actually not possible to die directly from cannabis ingestion. Now, I think some of your so the answer is no, we're not seeing deaths go up for that. Dosing, I mean, the strength of the available product is something that I do think we need to pay attention to, and some of the earlier witnesses talked about. The potential for getting, in some states now, THC extracts that are 90% pure, and I don't think we know what the implications of that. But you're not going to die from it, but it may induce a psychotic episode that could lead you to do something stupid that would kill you. Yeah.
Right. Okay. And I don't know. You don't necessarily need to go back to the map, but I noticed on opioid deaths on the map, the dark blue area, there was a high concentration in the Midwest part of Georgia, Coweta County, Carroll County, Troup, Paulding County, those areas. And I know there was a study done on the opioid epidemic and just looking at all different factors. And I know my home county of Coweta County ranks 6th worst in the state. Is there, I mean, during your study, did you find any particular reason why that part of the state looks to be concentrated more so than the rest of the state? It was kind of a little here, a little there, but over there was 4 or 5 dark blue counties. Is that I mean, is that due to I-20 and 85, and it's coming out of Alabama, or I mean?
Yeah. And I should say those were unadjusted for age. If I had presented age, those are just the raw numbers from the vital statistics data, the data you heard mentioned earlier today. If we had presented age adjusted, what you would basically see is the going from the most northeastern corner of the state down almost through Atlanta, just north of Atlanta, and to the sort of Midwestern region. That whole area is really suffering. And the research suggests that it's things like poverty rates, lack of being medically underserved areas, having a higher age population and a population that's more vulnerable. Those are the kinds of things that are driving the underlying opioid use disorders and that are unfortunately translating into higher levels of death.
And I apologize to everybody because that was a little off topic, but I'm just a concerned legislator that
for sure.
cares about my state and especially my area. So, are there any other questions from the committee? Well, Doctor,
right.
thank you so much.
Thank you
That
very
was
much.
Wonderful. All right, y'all, we got 21 minutes, and then we're going to try to get through these public comments. If you're here and you've spoken before, and you have something new, we'd love to hear it. If you're going to say the same thing, just get up and say I have the same. I want to add the ×2. Just say ×2, and we'll mark that by your name. But first off, let's go with Grace Byrne. Grace, I think her father is here. Okay, Mr. Byrne's going to come and speak on behalf of Grace. Grace had actually come to the Atlanta meeting, could not make the Carrollton meeting, and so. But they're from here in Athens. So.
And she could not make it today because of the issues associated with her needing medical marijuana. So, my daughter Grace, 5 years ago, suffered a traumatic brain injury here in Athens when she was hit by a truck, an SUV on Village Avenue. In that 5 years, the amount of good sleep she's gotten as a result of the PTSD from this accident, non-existent. So we're grateful that she can legally now try, and we tried different mixtures to see if it'll help, but we can't get it, which makes it hard to get advice from medical professionals. What are the right mixes? What are the right blends to make the medicine effective? I was in Arizona taking my daughter to school in August, and I want to make sure we don't have the horrible advertising here they have in Arizona with their law. I mean, their version of Flagpole is 5 pages of medical marijuana dispensaries. We don't need that. But I was able to go into an evaluation clinic and say, hey, can we talk about different strains? Now, I can't buy it here and bring it back, but I was able to talk to them and get advice on which strains to look at. In this context, I'm moderate to ultra-conservative in some areas. My brother died on December 10th at the age of 59 as a result of his lifelong drug and alcohol problems. Right? My sister is permanently disabled because my mother, when she was pregnant, she had been pregnant with her because of the illegal pharmaceuticals she was taking for seizures, Dilantin and phenobarbital. My sister, as a result, was born with a chemical imbalance and just basically disabled for life, because back then nobody thought about medical marijuana being accessible. So, in due respect to the other speakers who spoke about their personal experiences in the past, that's nice, but don't put your personal experiences on us. Right? Let us have the right to try and access these medications. Let's find a way to put this in place. There's ways to do it. I take a medication, it's a maintenance medication, it's a Schedule 2, which means that every 6 months I have to go to my doctor and give a P-test to make sure I'm not taking other drugs, that my taking this medication has not led to further drug use. We can do the same thing with medical marijuana. You want access to it? Take the test. If we see other drugs, your access is cut off or computerized, a dispensary can say, your card is no longer valid because you failed this drug test. There are things we can look at. We need to look at other states and how they're doing it. In Arizona, if you don't live within 25 miles of a dispensary, you can grow your own. That helps the problem with access to dispensaries, especially in rural areas like that. I don't know that that's the best solution. Right? But there has to be a solution that gives patients like my daughter and the other 6,000 people in Georgia and more who need to sign up the ability to access it legally and to get good medical consultation on what the best mixes are. Because, like I said, it's not one size fits all. And I appreciate the economist who just spoke that just gave us peer-reviewed literature that says that opioids go down. When my brother died, I never thought had the opportunity to talk to a homicide detective in Baltimore. It wasn't Munch, for those of you who remember that old show. And I asked him, how many people die a year in Baltimore from drug overdoses? In Baltimore City, it's 700 to 1,000 people a year dying from drug overdoses. I asked him, how many of these are from marijuana? He said, the only time marijuana overdose is an issue is when it's been laced with fentanyl. Nobody has died of a straight marijuana overdose, of 700 to 1,000 a year. So there are organizations out there. Leave me alone. Leave my daughter alone. Don't push your values on us. Don't push the fact that your child died from an overdose and you come from out of state on us. We're the parents. We'll watch out for it. Yes, everything can be abused. That's a fact. Punish the abusers, not people using it right. Thank you.
Thank you, Mr. Byrne. All right, Lisa Germain. Is Lisa here? And Mr. Byrne did a great job. If everybody just keep your comments to 3 minutes so that we can let everybody be heard and get out of here on a good time.
Have a big font.
Thank you, Lisa.
All right. My name is Lisa Germain. I'm speaking to you not only as a mother of a son with epilepsy, but as a direct healthcare provider in a level 2 trauma hospital here in Athens. Each day in my job, I encounter the effects of our out-of-control situation with benzodiazepines and opioids. I completely understand the concerns about access. Oh, sorry, can you hear me now? Oh, I feel like an advert. Sorry. Okay. I completely understand the concerns about access to other types of I completely understand the concerns about access to another type of mind and mood altering drug. So the far-reaching ramifications of the legislation really need to be looked into. Make sure that we just get to the right people and the right people, help the people that need it. However, from anecdotal evidence, it would appear that THC has had great potential benefits for the patients, and I see that at work on a regular basis. In discussion, though, with other pharmacist co-workers, I have a sense of optimism about THC use, but also concerns about the lack of intensive research. So that's one of the things that my co-workers have said, that we don't have the research there, but anecdotally, the evidence is far-reaching. As I have already stated, the anecdotal evidence appears overwhelmingly positive for the use of THC, and our son is a prime example of this. Last summer, with only 2.5 semesters left to go in an aerospace engineering degree, our son was knocked off a bicycle and suffered a near-fatal head injury. After emergency neurosurgery and a month stay in ICU, 3 weeks of which were on a ventilator, and then more neurosurgery to replace his skull and 15 months of ongoing rehabilitation, his rehabilitation is progressing, and he hopes one day to complete his studies at college. One of the effects of the head injury has been his ongoing seizures, with finally an epilepsy diagnosis. Of all of the issues and struggles facing our boy, watching him sit and wait for the next seizure was almost unbearable. Watching our child in absolute terror as a seizure takes hold and dealing with the aftermath, the exhaustion, the aphasia, the inability to speak, and the depression that came with it was almost intolerable. His wonderful neurologist was confident in his ability to control the seizures, but after very high doses of 3 different drugs with continuing seizures, he did not want to try another 4th tier that would then further sedate our child. So he said, I can give you this card. It'll help you if you get the THC, but I don't know where you can get it, and I can't tell you how much to take. But we will figure this out together if you can figure out a way of sourcing your THC, low-dose THC. So here we are, 4 months later. The seizures are now no longer 2 weeks apart. Our son is starting to interact in the community again. He's helping out with his high school football team, gained some long-lost confidence and independence. We're finally fine-tuning his dose, and our fear is that if we lose the access to this THC, what will be the outcome? We'll start back to the 2-week cycle. As I said, as a healthcare provider, I cannot lose my license as a physical therapist, and I cannot have our son, of whom I am his legal guardian because he's a ward of state, taken away from the home if we break the law to try and get his medications. So we need help to make sure that we can get what we need for him in a legal and safe way, because the last thing we need to do is have him end up taking some sort of drug that ends up doing something else to him. We need to keep it pure, we need to keep it safe, and we need to keep it monitored. And thank you very much.
Thank you, Lisa. Gregory, Ashley Slayton, Dave Baker, and Mary Byrne. Just stand right over here under the screen, please. Thank you.
Appreciate the opportunity to make comments before the commission, and thank you for all the work that you're doing on this. Have to refute some of the things that were previously said. It is true that people don't overdose on marijuana, except as the rates are going up at THC. That may become more prevalent, as Dr. Spencer was saying. But people don't OD on smoking a pack of Philip Morris either. It's the effects. In Colorado, traffic deaths related to marijuana are going up. One person dying every 2.5 days on the roads in Colorado. We don't know how many people are dying each week on the roads in Georgia because we don't measure for THC metabolites in the blood of deceased or impaired drivers. My background is substance abuse treatment and prevention for the last 40 years, so my heart goes out to people who are suffering from the disease of chemical dependence. My world is really different than the world that has been presented so far. In that my world is the world of Darrell Rogers, the parent that you heard from at our first meeting in Atlanta, the parent who lost his son to marijuana. I speak with lots of parents who have lost their kids to marijuana or to a drug that marijuana led to, and it's very, very difficult. I would say that there is a great deal of research that talks about cannabis use being associated with substantially increased risk of non-medical prescription opioid use. That's from the American Journal of Psychiatry. That's a rather respected, peer-reviewed journal. Addicts, or people with chemical dependence, people with substance use disorder, tend to get their hands on whatever they can many times if their addiction has proceeded. And it's not as clean and neat as, oh, I'm going to switch from one drug category to another. I wish it were that simple. I wish the solution were to one drug was another drug. But let's also recall that cannabis use disorder is also a substance use disorder. There have been studies done for the National Epidemiological Survey on alcohol and related conditions with 34,000 people. Found that marijuana use appears to increase rather than decrease the risk of developing non-medical prescription opioid use and opioid use disorder. So that's opioid addiction. And again, that was a study with 34,000 people in it. There are papers from the National Institute on Drug Abuse that talk about marijuana use associated with an increased risk of prescription opioid misuse. And I have copies of this article for the commission that I can leave with Elizabeth. The Lancet is probably the most respected medical journal in the world. The Lancet recently came out saying, we found no evidence that cannabis use reduced prescribed opioid use or increased rates of opioid discontinuation. So there's a lot of research there that's a little different than what the commission may have heard.
All right, next up, Ashley Slayton.
Hello, good evening, good afternoon. My name is Ashley Slayton, and I'm a representative. Well, I'm a citizen out of District 4, DeKalb County. And I thank you guys for starting this in 2014. It's really needed, and it's really need to be heard. I'm a veteran, 30 years old. At the age of 25, excuse me, I sent you 21, Senator, I meant 25. I was honorably discharged out the military. Well, what occurred in there is I served in both Iraq and Afghanistan as a combat veteran. When I was in Afghanistan, I worked with the 110th Mountain Division, and we've done hard, those guys really did their thing, but my job was to provide shelter and a place for them to stay, and out of that, 70% of fuel as well as 90% of materials was able to be routed to safer places for these guys to come back home to view their families. So I'm saying that to say this, I'm a problem solver. Cannabis, well, let me back up. During this time of working with the 110th Mountain Division, I was sexually assaulted from the time of October this month, which we all know about muscle memory, until almost January 1st. Since I've been in the military, I've always deployed around the holidays, including my birthday, December 13th, in which one of these sexual assaults happened. The day that I decided to allow my supervisor, who's a senior NCO, he decided that I talked too much, choked me, and I body slammed him. Therefore, that broke up my vision of what a family is and who I really am. So I come today to the group and saying this: when I started to smoke cannabis, and with my partner of 10 years doing, spouses, how they talk and congregate amongst each other. It's periods that I go into a state of psychosis. I will send you the audio of it. She'll roll my joint, sit it there. I go and I smoke it, and guess what? Excuse it, I developed syndrome. And it does help me personally. And I just want, everyone to take it honestly, why I came here today, because I feel like you guys do not represent me in a certain form of fashion wholeheartedly. And I would like to be on this board as a citizen appointee out of District 4 because I contacted Hank Johnson. He had no clue about this. But I'm from a county where they pride themselves on agriculture. I mean, that's in their mission statement, actually in their logo. So it is ways out here to get information so we can have both more opposing and, for and against, and come up with a solution. But you guys are going to be so busy. How are you going to get the information out there? I believe I can do that. I've talked to several people who are against, especially in the VA system. They just don't know. That's all that's about. The information is not given to them. And I'm just here to say that, and hopefully that was something new, and you guys have a good day. And I think, and to the law enforcement, guys, honestly, they're here to help too, and I know we all have our differences, but when we come together, it's gonna all make sense. Everybody's gonna be happy. So thank you for your time, and you guys have a good day.
Thank you, Ashley. And just a quick comment, Representative Johnson's at the federal level, and this was a state law, which is why he didn't know about it, probably.
Okay, that's no problem. When I contacted, not the congressman, I forgot the one before him, she told me to contact him, and I had to make sure, like, hey, am I talking to the right people? But no one, when I reach out to you representatives, no one ever hit me back up. And it's just a simple yes and no. I'm an adult, so it's okay.
Fair enough. Okay.
Thank you.
Thank you. All right, next up, Dave Baker.
Mr. Chairman, members of the commission, thank you so much. Since today's topic is experiences in other states, what I want to do is put in the record an op-ed that just appeared in the Denver Post last Friday. It's called "It's High Time We Took a Breath from Marijuana Commercialization," and it's written by Bob Troyer, who is the U.S. Attorney for the District of Colorado. I'd like to share some excerpts from that as my statement and then leave you written copies here. So again, these are the words of the U.S. Attorney for Colorado. In 2012, we were told Colorado would lead the nation on a grand experiment in commercialized marijuana. 6 years later, it's a perfect time to pause and assess some of the results of that experiment. Recent reports should be enough to give everyone pause. Now, Colorado's youth use marijuana at a rate 85% higher than the national average. Marijuana-related traffic fatalities are up 151%. 70% of 400 licensed pot shops surveyed recommend that pregnant women use marijuana to treat morning sickness. Colorado has issued over 40 recalls of retail marijuana laced with pesticides and mold, and Colorado has a booming black market exploiting our permissive regulatory system, including Mexican cartel growers. Again, this is Mr. Troyer. Yeah.
Just for sake of time, most of what you're talking about is recreational marijuana. We're here to talk about oil and access of that oil.
I understand.
So please keep your comments to that. I'm not trying to cut you off. For sake of time, I've got a lot of people that want to speak, and this is a message to everyone. Please stay on topic.
Mr. Chairman, I'll keep this to 3 minutes. You said the topic was what's going on in other states, and this includes this includes the cultivation and dispensing, Mr. Chairman. As the U.S. Attorney leading other states on marijuana issues, I've heard what people are saying about Colorado. Do they tout our increased tax revenue? No, because there has been no net gain. Do they highlight the elimination of the black market? No, because our black market has actually exploded after commercialization. Do they promote our success in controlling production or containing marijuana within our borders? No, because last year alone, the regulated industry produced 6.4 metric tons of unaccounted for marijuana. Does the industry trumpet its promised decrease in alcohol use? No, because Colorado's alcohol consumption has steadily climbed since commercialization. How about the industry's claim that marijuana will cure opioid addiction? No, a Lancet study found that heavy marijuana users ended up with more pain and are more likely to abuse opioids. Yet, on that last point, the marijuana industry is trying to exploit our nation's opioid tragedy to push its own controlled substance as a panacea. Why? It's a profit opportunity. I'm not sure the 55% of Coloradans who voted for commercialization in 2012 thought they were voting for all of this. We should pause and catch our breath before racing off again at the industry's urging. Unfettered commercialization is not inevitable. You have a say. Thank you.
Mary, did you? Okay. Melissa Kimball, Nicole, and Cass Green. Okay. Melissa, you'll be up first.
Thank you. In 2005, I had a back injury that completely turned my world upside down. It led to 15 different pharmaceuticals for 12 years. Chronic pain, addiction, panic attacks, suicidal tendencies, and PTSD. It took 6.5 years. Today, I'm proud to say I'm 425 days pharmaceutical-free since 2005. Marijuana saved and changed my life. I'm not a criminal. I'm a pastor, an advocate, a wife, a mother, and a friend. No one should ever be told how they treat their mental illness, especially a United States veteran. God provided every plant for food and medicine. God is my judge and jury. I might go down, but I'll go down fighting. Honestly, I'm incredibly tired of fighting with the state of Georgia, and it has to end. We as patients demand in-state cultivation. This past Veterans Day, a retired United States Marine wrote on his Facebook page, "Do not thank me, do not pray for me, but help me." Thank you.
Melissa. Nicole.
Good afternoon. Thanks again for allowing us to have a moment to speak, committee. Be candid with me. Are any of you practicing physicians or doctors or went to medical school? No, right? Okay, so technically, I think there's a law that says if you practice medicine without a license, then you're committing a crime. When the legislators, my lovely legislators of Georgia, decided to make a law that determines how much of a medicine I can use, aren't you practicing medicine without a license? Okay, well, my point is, I really would hope that the legislators would understand how important it is to allow patients and doctors to make that decision for their best treatment. And I understand that that's what this is about, providing safe access. But I use medicine that is more than 5% THC because it's what I can get a hold of right now. So what I fear more than a criminal record is getting arrested with my medicine on me. And they putting me in prison while they test my medicine to determine if it's 5%. Will I be forced to take the medicine that the state and the prison provides me? I'm vegan, and that's the best way that I can fight my disease. So
Nicole, real quick, just to be fair,
Yes.
Stay on task. We're not here to debate 5%.
Okay, just safe access, right? So safe access for me. Right now, I have to get my own medicine. And so what is the state going to do to make sure that if I am caught with medicine, that I don't go to jail? And I believe a statewide decriminalization would help to do that. In the meantime, while we're figuring out safe access, while we're figuring out dispensaries or how we're going to get medicine to patients, in the meantime, make sure that those patients don't go to prison because they just want to have access to their medicine. And so that's what I would like to add to my previous presentations is just making sure that I can stay out of prison while I'm trying to access because I don't plan on being in the state long if I have to continue to worry about my freedom. So thank you all.
Thank you, Nicole. Cass?
Hello. All righty. I'm Cass Odom. I am the National Director of Public Policy and Research for Minorities for Medical Marijuana. I'm the Policy Director for Colorado Black Women for Political Action, and I also serve on the Operating Board for Reform Georgia, which is a criminal justice organization. As a research analyst, I'm not fond of lies and misinformation, so I just want to make a couple of corrections. This is from the Gazette, August 24th. This is out of Denver, Colorado. The number of highway deaths involving Colorado drivers who have marijuana in their system has grown in 2017 because, of course, marijuana stays in your system. That's not rocket science. Okay? So at the same time, traffic fatalities in which drivers had enough marijuana in their bloodstream to be deemed legally impaired dropped sharply. So I just want to correct the misinformation that's been put out there because cannabis is not the problem. Okay? So let me get on point with this. I survived 2 spinal fusion surgeries, and I had a near-death episode with MRSA. I left Georgia and moved to Denver, Colorado so that I could partake in medical cannabis because I was developing such a bad reaction to opioids, and I saw where this was going to lead me on an addictive path. And when they wanted to send me to a pain management clinic, I said, it's time to move. And my mother also self-medicated for MS and cancer. So I am very much an advocate for legalization. There are several areas that I know that we can improve the laws here in Georgia, but what speaks resoundingly to the fact that Georgia's citizens are ready for legalization is that we're passing ordinances all over Georgia. These ordinances are proof positive that the citizens of this state are ready to move forward. And one thing that drives this point home and how awesome this could be for the state, the revenue. The revenue itself is tremendous. Washington State actually, I love these numbers. I like to talk money when it comes to policy. So Washington State CFO has proposed adding $700 million into a rainy day fund outside of operational expenses for the state. That's incredible. What that could mean for Georgia is insane. And they are now selling municipal bonds in Washington, of which the largest bidders for these municipal bonds were Morgan Stanley, Bank of America, Merrill Lynch, and Wells Fargo. These competitive bond sales on March 6, 2018, they raised over $5 billion. $5 billion. What that could mean for Georgia, the impact that could have on Georgia is enormous. California as well has a rainy day fund that they're adding into $43 million just in the second quarter of this year. Washington and California are awesome, but Colorado, their tax revenue up to 2018, August 2018, for this year alone, has they've accrued $176,940,258 in tax revenue in the second quarter of this year. So this is incredible. These numbers are incredible and what that can mean, but what I love that's going on in other states are things that we need to take a look at. Social equity programs must be a part of policy synthesis. It cannot be an afterthought. We cannot look at social inclusion of communities who've been economically disparaged by the war on drugs and make it an afterthought to make sure that these people are included in this industry. We can't have big dollars coming into Georgia and Miss Janie's been mixing, shea butter with cannabis oil for years, only to have it remixed in a bottle by Estee Lauder. We can't do that as Georgians. We owe our citizens more to make sure that this industry is inclusive. Lastly, Coca-Cola knows it's the real thing. They're in our backyard. We're having industry surround us, North Carolina, South Carolina, Florida, the Caribbean. So I'm just begging the commission to really take a look at the money, what this could mean for Georgians. And I, as a Georgian, a native Georgian, will be leaving Georgia again if this doesn't pass. And I'm a gainfully employed taxpayer.
Thank you, Cass.
Okay.
Appreciate it. All right, next up, Pat Doherty, Divine Thornton, Lee. I can't read the last name. You'll come up. Doherty's gone. Mr. Thornton? Miss Thornton? Come on, Mr. Thornton. And then Lee, if you'll come on, be right. Okay, you're right there. Thank you.
Let me go ahead and adjust this. Greetings, everyone. My name is Divine Thornton. I'm a community organizer in Atlanta, Georgia. We host educational cannabis events, community gatherings, workshops. We work with local advocacy groups, businesses, ancillary organizations, out-of-state speakers, and so much more. I just want to thank you guys for hosting this today. Thank you guys for having me. And I'd just like to share a few notes with you guys just as we sort of progress throughout today's meeting. We've heard several plant touching opportunities. However, it's important for us to consider ancillary non-plant touching opportunities such as products, packaging, technology, accounting, law, and more. We've heard the importance of providing commercial companies with a proven track record the ability to obtain licenses and operate here in Georgia. However, it's also important that we ensure mom and pop small business owners have the opportunity to participate in this industry as well. We've also heard, however, earlier how several license holders in Florida and several other states are funded by large corporations and investors outside of the state and even the country. Therefore, we need to ensure GA citizens have the opportunity to create collective cooperative business models to pool resources together to obtain licenses. It's also important that we create multiple license types at various price points. It's important that we provide educational platforms and opportunities for individuals to learn about the various dispensary, cultivation, delivery, testing, vertical integration, and so on throughout the state. It's important for us to consider diverse ownership and management teams. For example, a person of color, a veteran, an individual with a disability, an individual within the LGBT community, and of course a balance of males and females. It's important that the future license holders have a past and present effort within the community actually getting to know what the citizens themselves want, and on the lines of education, advocacy, organizing, and really know what's important for the community. It's important for us to understand that we may not be here to discuss recreational and adult use. However, when we say access, we must understand that whether it be a patient, an advocate, an entrepreneur, an enthusiast, a professional, or just someone curious, we all deserve access to consume cannabis, however we may choose so. Lastly, it's important to understand that the war on drugs has played a very huge role in dividing us as a race, and now, more than ever, we truly need to remove the colorblinds and work together as one community to push this effort forward. So, ladies and gentlemen, thank you. It's our time and it's our turn. Thank you.
Thank you, Divine. Lee?
I'm going to be real brief. Thank y'all so much for doing what you're doing. We really need this access. Now, what I am going to touch point on is I come from Watkinsville, Georgia. My sheriff just left, Scott Berry. And I did a lot of my life in the penitentiary for cannabis. I won't call it marijuana. I'm not William Randolph Hearst. What you're doing here is the most awesome thing I've ever seen in Georgia. I grow in California. I grow in New Jersey. I grow in Michigan. I want to be home. My father is 73 years old. I'm currently helping one of my uncles who's died of cancer, cured a bunch of people of cancer here in Georgia. Of course, that's way above your 5%, so we're off task there. But it's a good start. And this is coming from somebody whose family has fought in every war since 1740. So there you go. Appreciate y'all. And I look forward to seeing y'all again soon, because I'm going to use all my gas and energy to get to you.
Thank you, Lee. All right, last three will be Eddie Self, Dr. Gregory, and Big Gip. So, Eddie, you'll be up first. Eddie here? Okay. Reverend, you ready to roll?
Thank you, Commission. Appreciate you all. I am the Mr. Right Reverend Gregory Carl Davis, an entity. How did I do that? Well, I got so deep into the Bible, I fell out the other side. So I got a prepared statement. I have distributed this to the Commission and gave a copy to Peter Skandalakis, I think is the name. So I want to read here, the cannabis strains vary greatly in THC and other cannabinoid content, and non-euphoric low THC oil products have shown medical benefit, even to the satisfaction of the FDA and DEA, with the approval of GW Pharmaceuticals' botanical extract Epidiolex as an FDA-approved Schedule 5 drug. Many of those that support access to cannabis for medical purposes do not understand that extraction processes as well as plant strains give rise to products that can vary greatly as to the amounts of THC and other cannabinoids such as CBD. There are no United States pharmacopoeia standards. Some oils or extracts are much more effective for a particular condition than others, even though all may be somewhat effective and safe. I believe that state medical cannabis laws should not be limited to regulation to cleanliness of product and anti-diversion controls. They should demand standards that assure citizens have access to effective cannabis products and also mitigate the personal legal risks to them of having to import federally illegal product across state lines. In order to supplement a patient's right to try with accurate information on effectiveness of any particular cannabis product, I believe states need to create registries to measure health outcomes, both positive health benefits and negative side effects, and establish procedures for independent review and communication of the results found in such databases. Few, if any, states currently provide for the protections and benefits of such outcome registries. I believe that state programs can provide a state framework in which real-world evidence can be collected to accelerate FDA approval of products in clinical trials through establishment of mechanisms to facilitate access to those products through expanded access and compassionate use procedures approved by the FDA. There also exists the possibility of obtaining FDA and DEA approval for manufacturing of products within the state of Georgia, including obtaining DEA approval for import of raw or finished potential. Pennsylvania is moving in that direction, while retaining the authority to approve cultivation, manufacturing, and distribution, and if that approach doesn't work. The anti-diversion focus of the Controlled Substance Act is based on the single convention treaty with the United Nations and the federal government. And although both make exceptions for medical purposes, the enforcement is structured and focused on prevention of harmful substances as a high potential for abuse for being available to the public. The core of enforcement of both the CSA and treaty relies on establishing quotas for production and tracking product to its end use or destruction. Most states have provisions that mirror this licensing and tracking requirement. I believe that the active resistance of the DEA to expansion of medical cannabis industry will be rapidly changing with the precedent provided by the finding that a marijuana extract has medical benefit. There are actually already established policies and regulatory provisions that can be used to allow this once the DEA moves from a prevent all to an enable medical posture with regard to cannabis. The challenge for you is in establishing a framework that harmonizes what the medical provisions in the federal cannabis law and regulations while retaining the right to try for all Georgians until such time as the products they need now can be obtained full federal recognition as having medical benefit through FDA approval.
Reverend, you're at 5 minutes, so I'm going to have to cut you off, brother. Thank you.
Didn't know it was so long. Apologize.
Big Gip. And your hanky matches your shoes. You're looking good.
Okay. Last time I saw y'all, how y'all doing? Last time I saw y'all, I left here, went home, got my bag ready to go home. Father called me. He said, "Yo, I'm sick." Father had to go to the emergency room. First time I ever had to call the ambulance for my father. He was on the bed, wasn't eating for 3 days. They hooked him up to the plasma thing. They couldn't stop his pain. His hands had swollen up to almost cantaloupe size. His legs were swollen, his feet were swollen. He told me, he said, "Son, I need you to go on back to work." Jumped on the plane, went back to LA, had a conference downtown, got a call from the doctor, Dr. Hodges. He said, "Bro, your father, he been through a lot, his body tired. I think you should come home. He fragile." Jumped on the plane, came back home. Before I got on the plane, I got a call from one of my friends. He's a scientist. He said, "Gip, come down to the dispensary. I got something for you." When I went over to the dispensary, he gave me this oil, this Rick Simpson oil. He said, "Gip, I've really cured 4 to 5 people in my neighborhood with this." He said, this is a combination of 5 different strands. This is a scientist. He doesn't smoke. He doesn't do none of that. All he does is messes with the tree to figure out different ways to heal people. I brought this stuff back. Me and my brother were in the room, my mother. The doctors, 3 doctors come in and they tell us that it's nothing else they can do. My father is possibly going to die in the next 24 hours. I said, "Okay, get everybody out the room." They leave. I take this oil out and I put it in his mouth. He hadn't been able to eat. He hadn't been able to drink anything. He hadn't been able to do anything. He slept that night. He woke up in the morning and he asked, "Can I have something to eat?" My father is at home right now. I'm telling y'all this because my father, when he was admitted into the hospital, he was in the transition unit. You don't walk out this unit. You go out on your back. 3 doctors walked into the room. He woke up 2 days later and he said, "I want to go home." Called the doctors, we said he want to go home. They all came in and they looked at him in amazement. We don't even know, "You don't hurt, Mr. Gill?" "Nope, I don't hurt." "Anything wrong, Mr. Gill?" "Nope, I want to go home." The doctors don't know I gave them this, right? My father is still at home. Now, I don't know how long he's going to be here because it's been 5 years of battling this cancer. But I'm telling y'all, from the time I walked into that hospital room, he was about to die. His fingernails had already partially turned black. Around the rims of his eyes were black. Death was creeping in his body. Once I put this RSO in his mouth, he woke up and said, "Let me get some Coca-Cola. I want some Butterfingers." I want some noodles. He hadn't been able to eat for 4 or 5 days. I'm telling y'all, this works. I got some, a lot of it, like I told you. A lot of it. And I'm going to keep him here as long as I can. I love y'all, man. It works.
Thank you. All right, everybody, that wraps up this meeting. And next we'll be in Savannah. And that date, off the top of there. What is it, Nicole? October 23rd, we're going to Savannah. So hope to see everybody there. I know we'll see some of you. Some of you won't make it, but that's okay. We're going to keep on fighting. So, again, thank y'all for being here. We appreciate everybody's time. To all our speakers, we appreciate you taking the time to travel. And to all of our, to the public, we appreciate you taking the time to travel. To the commission members, I appreciate y'all taking the time to travel because this is an important issue. So with that, thank you, Chairman Gravely.
I'll say this. We are the commission. We support this issue. We wouldn't be on this commission if we didn't. Here's what I would task all of you out there. Call your representative. State representative, your state senator, and tell them you are following the work of this commission. You would like them to vote for the work that the commission brings to the legislature. We hear you. We appreciate you being here. But we're only 1, 2, 3, and the other 2, we're 3 votes out of a 236-member legislature. So us 3, Senator Miller, Representative Powell, will put together legislation, hopefully, take it to the legislature. We will need 230 members to support that measure. So we're going to rely on y'all to contact your representatives. Thank you guys for being here. Yes?
Because it's against the state law. That's just to answer your question, what we are doing, the whole purpose of each and every one of these meetings is to compile information. We're all learning. This is something that's going to have to be built from the ground up. And so we're having to look at what other states are doing to help us. And then after all these meetings and after all the information that we're taking in, and we're looking at best practices of other states, we're going to issue a report. And we'll issue that report probably sometime in December. The legislature goes back into session in January. So we can't create a law right now because we're not even in session. So we will issue a report that makes a recommendation to the legislature. And then more than likely, one of the members of the legislature that are on this commission will carry forth a bill or a series of bills and try to get them through the process, which means it has to go through committee, has to get in both the House, it would have to pass the House, and then it would have to come to Senate committee and go through that process and then pass the Senate and then be signed by the governor. So that is kind of the process, and it could start in the Senate and go to the House. That's tit for tat, doesn't matter, but that is the process. So we make a recommendation. This commission will make a recommendation to the legislature, and then it's up to the legislature to act on that recommendation. That's not what we're tasked with. We are looking at access for legal oil, low THC oil. That's all we're looking at. you have low THC oil and you have one of these illnesses, and you have a card, you are not breaking the law. To get it, though, I am breaking the law. To get it, which is what we're trying to fix.
You gotta have to remember, in 2014, this doesn't happen overnight. Those diagnoses that we read, that was part of the first bill. And we didn't have the votes to pass that. You had members of the legislature said, I'm not gonna vote for the bill. So we didn't have anything. Shannon Cloud being there. So we've brought forth measures and had to fight for every single piece of it, because you gotta find something that the majority of that 236 is going to vote for. So, and I'm glad. I mean, I'll tell you what, Dave Baker, I appreciate you actually giving us this, because it shows me how Georgia's doing it better than Colorado. How Georgia's doing it. Colorado, and I'll say it again, came to our first study committee and said, don't do it the way we did. And this information just backs that. This tells me Georgia's on the right track. This tells me we're taking a very strategic, a very calculated move forward so that we don't run into these problems. And this is recreational. We're not even talking about recreational. So you don't hear that coming out of Iowa. You don't hear that coming out of Texas. You don't hear that coming out of Virginia. This is coming out of Colorado. And they went Wild West. Yes? Oregon, we are looking at Oregon. We are going to adjourn so that the stream can stop. We will carry on conversation afterwards, but the meeting is adjourned. Thank you, guys.